is organizing the 23rd webinar, which is a continuous session with us every month. This is the it's not going. Okay. So this is the 23rd webinar on hip instability, a surgeon's nightmare, a problem which most of our colleagues and all of us face from time to time, and we have to deal with this. We'll be discussing on various aspects of this difficult issue of dealing with the hip instability. This will be convened by Dr. Manoj Wadhwa, the famous surgeon from Chandigarh. The secretary, Dr. Rajkumar, will also be with us in this. We have a special invitee, Dr. Luigi Zagra, head of the Department of Institute of Orthopedics from Milan. He's an old friend, and he kindly agreed to be part of us in this webinar. Dr. Pachore, Dr. Sen, Dr. Vijay Bose, Dr. Rajesh Malhotra, Dr. Bhende, Dr. B.D. Chatterjee, Dr. Anup Dhirani, Dr. Pradeep Bhosle, and Dr. Krishna Kiran will be part of this discussion from time to time. We will be organizing this webinar every month on every third Thursday. The next webinar that is going to come is February 17th. Kindly note in your calendar on choosing constraint in primary knee. As you know that we alternate between the hip and knee. So this webinar is on the hip issues. The next one will be on the focus topic of the knee. Convener will be Dr. Vikash Kapoor from Calcutta. And friends, lastly, I'll request you to convince your friends and colleagues to become the member of Indian Arthroplasty Association. We already have the membership to 705. Becoming the member is very easy. Just mail me or Dr. Rajkumar on the mails given over here, or just go to our website and join to become the member. I'll just give the podium to Dr. Manoj Wadhwa to carry it forward and start the webinar.
Thanks. Thank you so much, President sir. Let me share up my screen. So friends, before we start on, I'm going to set the stage right for what is going to be there in the next 90 minutes or so. We have changed a bit of the itinerary, the way the event runs up. We will have an introduction, the setting the stage process. Then Dr. Luigi Zagra will be presenting on dual mobility and constrained liners. Beyond that, we have 5 small orations. And then we'll go on to a combined panel discussion. So all the Q&A questions, answers, whether in the chat bot or in the Facebook or among the faculty, will be taken up during the panel discussion. So talking of hip instability, it is a major cause of dissatisfaction for both the patients and the surgeons. As per different reports, in a primary, it goes between 0.3 to 10%, but in revision cases, up to 30%. So whenever you have these instabilities presenting to us, we definitely have to go into clinical examination, the proper radiographs. In today's time, the standing and the sitting views. Patient factors cannot be ignored because a lot of things like ankylosing neuromuscular are things. We will be talking about the at-risk patients, that means the neck, femur or fused spines during the course of a day. And you have to work up pretty well how you're going to organize, and experts are going to give you all inputs because it's not explorated lab. You need to prepare on your implant inventory and identify what is the root cause. So the contributing factors can be impingement, whether it's intra-articular or extra-articular. Any sort of soft tissue laxity, which can be addressed by advancement, you're going to be seeing on the high hip centers, any avulsions of the greater tuberosity, and Professor Malhotra will be touching on this topic. One of the prime causes for late instability is the polyethylene wear, which we'll be seeing. And the contributing factors are the medial and the vertical offset. This low medial offset would cause increased instability, and the head-neck ratios will be discussed through. A very interesting is the hip spine syndrome and the spinopelvic pathologies. talking of the pelvic incidence, pelvic tilt, sacral slopes, and what to do in fused spines. And none else than our dear friend, Dr. Vijay Bose, will be speaking on this topic. Malposition is a very important pertinent. You might require a femoral or acetabular correction for correcting this malposition. Acetabular malposition is one of the biggest cause for component failure, regardless of what is the bearing material or the size of the poly. Now, talking of management options that we'll be discussing on will be the larger heads, the axial heads. They decrease the risk of dislocation by improving head-neck ratio. But we need to understand these bearings are not effective if abductors are not functional. Talking of the hip center errors, augmenting soft tissues, whether we change the neck length or the offset, any sort of trochanteric advancements, how to manage these bald trochanters. On the modality, we'll be discussing on the face-changing liners, the lip liners, which can itself become a source of impingement. Professor Luigi Zagra will be discussing on these constrained liners, the cemented as well as the uncemented, with the upsides and the downsides, talking of dual mobilities, whether they're cemented, uncemented, anatomic, or modular. Or the newer thing which is coming these days, we are reading on the articles on constrained dual mobilities now. We will also be touch basing the role of enabling technologies, the computer navigation and robotics in total hip replacement. And in an ascending parameter, whether we should be using where to be specific for a large head, where to use dual mobility or constrained liner. And all these things supporting us as lifeboats in catastrophic situation. But the point to understand is many times these lifeboats also fail. And these are the kind of failures that you'll be also seeing in the part in the case discussions, whether you can have dislocations of your constrained liners or dual mobilities. So with this, we set the state right, and I would pass the baton on to Professor Luigi Zagra to give us a run through on dual mobility or constrained liners, how to select.
Hello, everyone. Can you hear me properly?
Yes, Chief.
Yes.
Thank you very much for the kind invitation. It's a great privilege and an honor to be here with my Indian colleagues, with my Indian friends. I thank the President, the Convener, the Secretary of the Indian Arthroplasty Society for inviting me again. I was with you some years ago, unfortunately not in person now, but at least we can share our experience on this tough topic, which is hip instability, really maybe a nightmare. Let's move on. It doesn't work. I will share again. It doesn't move on.
We can see you.
You can see me.
Yeah.
Okay, now it works, I think. It's okay?
Yes.
These are my disclosure that should be considered because, of course, you will see the implants that I usually use. We have collaboration mainly for research purposes in our institution with different companies. So as we heard before, dislocation is a big issue, and it is still a big issue nowadays, despite the fact that there is a general decreasing in dislocation due to improvement of the materials, the knowledge, the new implants. It is still the first reason for revision in the first 6 years. These are very objective, real data from the Australian Arthroplasty Registry, and it is the third reason at any time. But it is for primary. When you go for revision, as we have heard before, it is the first reason for second revision after a first revision as dislocation. So be aware when you do a revision of the high risk of dislocation. But when you revise a hip because of dislocation, the risk of redislocation is twice. So there is a huge problem to control this type of problem and to make our patient happy and to avoid this nightmare for ourselves. But the first concept that I want to point out the importance of the problem is that this is a multifactorial problem. So there are several risk factors that need to be addressed before surgery: neurological or psychiatric disease, abuse of drugs of alcohol, congenital or acquired muscular insufficiency, old age, high ASA score, spine deformity and stiffness, with the increase in knowledge and awareness about this that we heard before, femoral fracture, DDH, post-trauma or post-osteotomy, previous surgery, high preoperative range of motion, very delicate and very precise cohort of patients, especially females, very dangerous, and of course, revision surgery. If it is a multifactorial problem, each factor needs to be possibly addressed. The patient, the surgery, including the soft tissue damages, as we heard before, and the implant, including the position, the biomechanics, and of course, the option that I will present in my presentation. So we have, first of all, a clear workup when we have this type of problem. And you need this in your mind, looking for the causes of dislocation, because there is no one unique solution, and you have to address the problem, the proper problem. You need a treatment algorithm for this, because there is no unique solution. And prior to select your implant, you need to do this. How we do this? Before speaking about the implants, you have the majority of your information through X-rays, the relationship between the head and the socket, if they are concentric, the inclination and the antivation of the cap, the height of center of rotation and the offset, the integrity of the greater trochanter, the presence of impingement as a tabular osteophytes, neck and greater trochanter posteriorly, and hip-spine relationship. How to do this? With the proper investigation. We need the unique state of the pelvis into view, looking at all these parameters, and then a shoot-through lateral hip, not only the femur, to understand the femoral part, but also the anteversion of the cap. And then, because of this increasing awareness about the huge problem of the spine relationship, spine in standing and sitting position, plus dynamic view. What is the reason for that? Because what we considered in the past as safe zones, we know now they are not safe anymore, because they are in some way dynamic, and most of the dislocation are inside the same zone. Look at this case. This is an anteverted cap. Nevertheless, the lady, 77 years old, dislocated after a real minor trauma 4 years after surgery. What's the reason for that? When you evaluate this in standing and sitting position, you can see that there is no change in the sacral loop, and there is a stiffness with this anterolastasis of L4. So this cap looks anteverted, but practically it is retroverted. And the conclusion for this first point that was just been published in our European journal, Effort Open Reviews, is that the stiffness of the lumbopelvic complex with the sacral loop less than 10 degrees between standing and sitting position are at risk of anterior impingement and posterior dislocation and needs an implant reorientation. Opposite situation, 81 years old females, 3 months post-op, posterior approach, anterior dislocation, but the implant looks okay. Offset is okay, no shortening, good anteversion of the cap. But if you look in the standing position, you can see this flat back. And when you look in more detail, we know that the patient with severe degenerating and rigid lumbopelvic complex and standing pelvic retroversion, there is a risk of posterior impingement and anterior dislocation. Again, you need an implant orientation. You need to prevent this type of situation. CT scan is helpful for cap orientation, but we don't know exactly the position of the pelvis during the CT. So take this with in careful way. And it's very important for the wear of the liner. We heard that this is a major reason for late dislocation. CT scan is helpful for this. Mass MRI is again helpful to evaluate the AB muscle damage, the presence of pseudotumor or fluid collection. This is a metal-on-metal small head problem. The lady dislocated a few years after the surgery. The reason was AB muscle disruption. So the most important thing that I want to introduce and stress as a concept is the restoration of hip biomechanics to prevent. This lady was operated with a minimal invasive approach on the left side, short stem, modular, while on the other side there was a standard approach with the standard stem. She dislocated on this side. Why? Because of the poor biomechanics. But of course, we have selected solution for the most difficult cases, both in order to prevent and in order to treat the instability. And these are constrained liners and dual mobility, the two main groups of situation out of big heads. This is the topic of my presentation. We know the concept of dual mobility, a small head articulated in a retaining polyliner, which is free of moving inside the middle back. This is not a recent story. This was developed in the 70s in France by Gilles Bousquet. And the interesting thing here is that the AB distance is higher and improves, increasing the diameter of the cap. This is exactly the opposite at the standard bearings. When you have a big cap and a small head, there is an increased risk of dislocation in this mismatch. With the dual mobility, it's the opposite. We have plenty of French literature reporting good survival with very low rate of dislocation. There were some issues in the past with intraprosthetic dislocation because of poor polyethylene, and also issues with the fixation of the cap that was improved in the next generation of implants with good results nowadays. And when we look at in a more international environment, for example, again, data from Australia, you can see that there is no difference in revision. This is primary hip. This is not revision. This is not all the reasons, all the diagnosis. It's just a primary osteoarthritis. And revision for a reason, there is no difference between dual mobility and the others. But there is a clearly reduced, lower rate of revision due to dislocation in the dual mobility group. We have evidence that it can work, at least in the short follow-up, even in the younger patients. We know that it prevents dislocation in patients at high risk of dislocation. And the use of dual mobility, even in complex cases such as cerebral palsy, can lead to favorable results. It can be considered a valid option to prevent dislocation in the most elderly population, and even better compared to bipolar when we treat fracture of the femoral neck. So, for the high-risk patient, dual mobility is at the moment the safest solution. So my indications are prevention in high-risk older patients in primary, prevention in high-risk revision cases, and treatment of dislocation in even in younger patients. This is a typical case. Look at the spine of the patient. Look at how it works. He is 80 years old. This is like a primary. This is a modular dual mobility implant, hybrid with a cementless cap and a cemented stem. Even in more severe cases, this is a young female with a severe mental retardation, complete no collaboration. She's blind. She's in a wheelchair now because of this right hip. And again, this is a hybrid dual mobility solution that worked in the lady. Indication in treatment is for the dislocation, unstable implants with an acceptable orientation of the components and no clear reason for dislocation, when a repositioning could be not sufficient. In this case, you can also change the liner if you have some modularity in your implant. And I want to stress here the point that when you have some systems in your hands, in your practice, where there is modularity on the acetabular side, when you can move from a standard bearing, can be poly, can be cross-link poly, can be ceramic, to a dual mobility or even to a constraint. This is very feasible especially for high-risk patients, because flexible systems that nowadays are available with different options can help you in the indication in this type of patient. What we have more experience is with this type of system, which is a cobalt chrome liner, is a modular dual mobility with heads of 40 and 42 according to the cap size. This is conventional poly sterilized in ethylene oxide with the 28 millimeter ceramics. And we started this experience a long time ago. It was since 2008, when it was not so much popular. But we use in selected cases, which is in primary, around 5% of our cases, revision, the high-risk patients, revision, which is of course more, while in the vast majority of cases where we have to treat an instability. We had, of course, complication even in this cohort of patients, not so many, infection loosening, but the dislocation in this high-risk population is not zero, of course, but it's not so high. 4 primaries, 1 revision, 3 reoperation, 2 healed with a close reduction. Some examples of this coming from our experience. This is a lady. She was revised because of polyliner with a cemented liner. She dislocated. The surgeon went to a skirted head. Dislocation again, you see she's dislocated inside the cast. In this case, there is no chance. Remove the cap. We go to a new cap with the dual mobility. What you can see here is a sort of spacer putting distally the center of rotation in order to improve the biomechanics, and then a dual mobility inside it, preserving the stem. Another situation, the lady was reoperated because of dislocation in this modular hip implant. But the problem was the destroy of the AB muscles. So we had to come in, she was limping, a new cap, remove the old one, and again went to a dual mobility with this space in order to improve the center of rotation, distalize the beat, and control putting the cap in more antivertial way. Another situation when you can just, if you have a modular system, just replace the liner. This was a conversion to a total hip from a EMI, no good fixation of the greater trochanter, dislocation, now good fixation of the greater trochanter, replace the liner, replace the head, and go to a dual mobility. On even a more complex situation, when you can have different reasons, different problems to be addressed. This is a multiple surgery. You see there is a quite high hip center in this young lady. Again, you can go with this spacer to distalize the center of rotation. Go to a dual mobility and control this huge bone, remove this huge bone that was source of anterior impingement together with the poor soft tissue and destroying of the AB muscles. And with the dual mobility in the young lady, it worked. But I want to stress another important point, that dual mobility this demonstrated a low dislocation rate in revision, but did not compensate for potential perioperative technical errors. So your surgery, your reconstruction of the beam must be as the best as possible. An example for that, if you have more than one risk factor, you dislocate even the dual mobility. You see, this male was Alzheimer's disease, malposition of the stem that is retroverted. When you put these two things, he dislocated. So we went in, we re-cemented the new stem with more offset, controlling the antiversion, correcting the antivation, and we had no more dislocation for that. Or in crazy patient like this, you can see where the dual mobility is. This is a typical COVID situation because this patient stayed for many months in this situation, dislocated during the COVID period. And again, went in, repositioned it, but be careful, dual mobility can dislocate in some situations. Finally, we have the option of the constrained liners. They give you immediate stability, but with a high number of mechanical failures, a short midterm follow-up. In the past, it was reported more than 30%, with some criticism, of course, about an overuse syndrome that it was in the past with the constrained liners. But it is strictly design dependent, and it is so much improved with the new liners. Look at this. Anyway, constrained liners have a higher risk of dislocation, even in primary, even if used in small number of cases, compared to all the other acetabular. Constrained have a higher rate of failure, even at the beginning, since the beginning. They have disadvantages. These are the reason you have reduced range of motion, even if better with new designs, as I mentioned before, and the high number of mechanical complications, including loosening, liner disassembly, early wear, and whatever. So we have very few indications, but not zero. There is some small space for that. For the older patients, nearly no indication in prevention, but treatment of salvage in recurrent dislocation, especially with severe damage of the AB muscle or neurological low demand patient. And which is probably the best situation, the best indication is the substitution of the liner in a stable cap in dislocating hips. I will show the case after that. This is a case. This is a complete hemiplegia due to trauma in this guy. He's not able to walk. Complete neurological damage on this side. This is for a constrained liner. Or this lady, she had a severe HIV hemiplegia. She had a fracture of the neck. She was operated with an hemiarthroplasty and she dislocated. And now we move directly to a constrained liner with the good rough surface of the cap, good constraint, and good screws to have good primary stability of the cap, which is under stress. And probably, as I mentioned, one of the best indication. This is a trabecular metal cap, extremely stable, but you have a severe tendinosis problem in this lady. You see the disruption of the AB muscle. It's quite easy here to remove the liner and go to a constraint in an already stable cap in this old lady. Or even in extreme situation, this is a total femur in this rheumatoid arthritis patient after several periprosthetic fracture, not able to heal. Total femur for the lady, dislocation because of the very poor AB muscle, and then cementing in the stable cap a constrained liner. In conclusion, how do I select person in my experience? I try to understand, first of all, the most important thing and restore hip biomechanics when possible. Dual mobility in high-risk cases in prevention and in the treatment is the first choice. Constrained liners are coming back because of new designs, but remain a safer procedure in case of severe neuromuscular damage. Thank you very much for your attention.
Thank you, Luigi. It was a wonderful presentation. A lot of difficult topic handled in a very explanatory way. Manoj, I think that we'll have the questions in the panel discussion.
Yeah.
Dr. Zagra, will it be okay that we have the questions for you in the panel discussion? And then,
of course.
Thank you so much, because you'll be part of the panel discussion as well. I'll request Dr. Manoj Wadhwa to speak for Dr. Pachore, as Dr. Pachore was not feeling well, but I will request Dr. Pachore is here. Manoj?
Yeah, Dr. Pachore, I think is online. He'll give his blessings. So you're around, Dr. Pachore?
So we wish him good health.
He'll be around for panel discussion. I'll be speaker for this evening because we don't want to miss his talk.
Yes.
So this talk is on impingement as a source of instability. When we talk about normal hip motion, this study by Kapanji that normal motion is 50 degrees of abduction and adduction, 40 degrees external rotation, 60 internal rotation, and 130 degree flexion and 40 degrees of extension. So this 170 degrees of flexion extension arc will be very difficult to achieve with a 32 mm or less diameter femoral head. So to achieve this normal motion is extremely tough. When we speak of impingement, as per different studies, the true frequency is unknown, but implant retrieval reports a range between 27 to 84%. Almost 50% plus cups showed impingement, with a couple of them severe notching. But the point to note is all these extended phalanges and anti-dislocation rims become high risk factors for instability and are generally not recommended. When we talk of impingement because of hard-on-hard bearings, whether it was a metal-on-metal causing metallosis or ceramic-on-ceramic causing fractures and squeak, these problems are identified much earlier by the patients and surgeons. Any manipulation of component can cause multiple problems, but one of the severe one it causes is impingement, which can be intra-articular or extra-articular. Any implant or to implant impingement, the most common like is we have our prosthesis in flexion and the liner in extension, which causes intra-articular impingement. Any bony ankylosis, whether it's a ischial femoral or the trochanter to the iliac crest or any sort of an osteophyte is a bony impingement. And soft tissue impingement is basically in the interior capsule and the scars. But the newer thought coming today is talking about the iliopsoas impingement causing interior groin pain. So all these implant to implant impingements are basically with small 22 mm heads. But the moment we jump on to a larger heads, which is 32 mm heads, our jump distance increases, but we get into more of a bone-to-bone impingement. Professor Luigi Acra also discussed about the safe zone, which we'll discuss more in the panel discussion. But today, with this paper from Ewing et al., we talk about the dynamic issues now. We talk about the pelvic tilt, which happens in supine and the standing position. And those conventional safe zones are nowhere in the picture. What we want to achieve as a target is somewhere around 40 degrees of inclination and 16 degrees of anteversion. And the mainstay to our hip surgery is the cup position, which is the basic issue with the majority of the instabilities. We need to be very pertinent onto the depth, that is the medial and the lateral position, the height, which is the superior and inferior, and the angular placement, basically speaking about the inclination and the version of the cups. So as conventionally Charlie told about the medializing of the cup. Now, medializing the cup is not done today because it increases the risk of bone-to-bone impingement. Similarly, if you try to lateralize your cups a lot, that is also unfavorable with regard to impingement and instability. Now the trend is more to achieving the global offsets. The global offset is a term which is the combination of your femoral offset, that means between the femoral head and the axis of the shaft, which is the marker of the femoral side, as well as the acetabular offset, which is the center of the femoral head to the teardrop. So this combination of femoral and acetabular offset is a global offset. There are multiple techniques to achieve it intraoperatively using special jigs or Ranawat's way of supraacetabular pin and trochanter, suture method, the coaxial stitch. Our dear friend Vijay Bose does it a big way. And cotyloid fossa, the cup should be proximal. The whole objective is you want to achieve the global offset as it was preoperatively or on the contralateral side. So the red line that you see from the femoral head to the vertical of the teardrop is the acetabular offset, and the yellow line from the center of the femoral head to the edge of trochanter is the femoral offset. Also, if you see on this lower slide, this dot out here, this is where we want to position our cups today. The inferior border has to be at the junction, which is midway between the teardrop as well as the lateral end of ischial tuberosity. If you're positioning your cups here, majority, you're going to have the right kind of inclusion of your cups. Also, it is found that the global hip offset post-operatively reduction of more than 5 millimeter is known to impair hip function post-surgery. Equally, during the course of the day, we'll see how to position our cups in cases where we have a spinal fusion and instrumentations. So in this cup, which Dr. Pachore told, was a patient where, because it was tough to relocate the hip, there was impaction of the femoral component inside, but it led to a trochanteric impingement onto the iliac side. So as a treatment modality, there was a distalization and centralization or lateralization of the greater trochanter, and abductor lever arm was restored. Along with that, so that it does not lead to a subsequent dislocation, the constrained liner was used in this case. On the implant factor, we are now moving on to large heads. We want to improve the head neck ratios so that there are less chances of impingement and subsequent dislocation. Skirted heads, which is a metal put onto this so that you don't have a breakage of the trinium, but these heads should be avoided because they cause a lot of impingement. And large heads seated deeper in acetabular liner will reduce the dislocation rate. Similarly, on the liner profiles, many times for a bed having a better containment and to have a new center of femoral head, we use these lip liners. These posterior lip liners, maybe 10 degrees liners, they definitely help you because dislocation is reduced from say 3.8 to 2.19%, but it comes at a cost. The disadvantage is the excessive wear, osteolysis, and loosening happening because of the torque factor and the impingement. So this is one factor which was, I think this slide is not coming properly. This is on the penetrative wear that any more than 4 millimeters of penetration gives you high torque forces and loosening of the cup. So whenever you have a patient with a groin pain, this is a Mayo Clinic criteria which Dr. Pachore follows. Any patient coming with groin pain after primary hip replacement, work on to the clinical history, physical examination, rule out infection, see the metal ion levels and taper corrosion. If everything else is in shape, you need to suspect on the iliopsoas impingement. If you're thinking in terms of iliopsoas impingement, you must try conservative therapies, physical therapy, NSAIDs, and local steroid injection. You have a relief, perfect. If no relief, go in for a lateral radiograph and see the acetabular prominence of the overhang. If you have more than 8 millimeters of acetabular prominence, you require acetabular revision. If you have less than 8 millimeters, that's a time to consider an iliopsoas stenotomy, whether you want to do it open or arthroscopic. So the main story is, can we eliminate impingement? The answer is no, but yes, we can minimize impingement. And how do you do it? You do a proper pre-op planning. You do your templating pretty well. You want to check on to the intra-op vertical and horizontal offsets, intra-op limb length measurements, as well as the techniques we discussed. And you need to trial your hips well in all 4 quadrants. You want to see on the superior in the abduction, inferior in the adduction. You want to take on your anterior impingement in internal rotation and posterior impingement in external rotation. So check in all the 4 quadrants. If you are fine over here, you are safer bet. So these are a couple of very small videos that in a couple of cases, you have these interior osteophytes, like in advanced avian, very delayed OA cases, you have this interior impingements, you have put your cup well with TAL or other landmarks. And beyond that, you are going to take off this impinging osteophytes on the interior wall. Similarly, on the posterior osteophytes, Once you put your cup well, this video is not showing up. Problem with the videos. But anyways, it's showing on to the interior osteophytes, the posterior osteophytes and combined anteversion. Not going up. But anyways, so talking of these osteophytes, if the moment you realize there are kind of inferior osteophytes causing ischiofemoral impingement, these inferior osteophytes need to be taken off. To summarize, impingement has high incidence than reported. Implant safe position has large variations. The head-neck ratio is solved, but large head is a priority, but there is no advantage of using heads beyond 36 millimeters. Pre-op planning and templating is vital. You should measure the horizontal and the vertical offsets. We discussed about the 4-quadrant impingement test. It is very important to do at the trialing stage. Hard on hard bearings are early recognized for impingement, and navigation may help you to reduce this complication and to look at the inclination angles. Thank you so much. And I think for the questions during the talk or the panel discussion, we'll involve Dr. Pachore for all these inputs.
Thank you, Manoj. Thank you, Dr. Pachore.
Thank you very much.
Wonderful.
Thank you, sir.
I'm coughing very badly. That is the reason I didn't want to,
Thank you so much, sir, that your great knowledge was shared with us. Now, the next I'll be requesting Dr. Ramesh Sen to speak on repositioning of the acetabular and femoral components. Dr. Ramesh Sen from Chandigarh. He's also the Indian Orthopedic Association President.
So, good evening, friends. Thank you, Dr. Rajiv, Dr. Manoj. So, I'll be talking about repositioning of whatever the factors Dr. Manoj just cited about from Dr. Pachauri's lecture. The malalignment, the impingement, there are many factors which can be there. So, I'll just give some examples, because whenever we think of instability, we might have to change the offset, as we just talked about, put constraint or dual mobility, revise a cup, revise a femur stem like this. Now here, this is way back in, I think, 210, when we had a case who had a 3-year-old fall where THR was done. 2 years later, it failed, revision was done. 1 year later, again failed, twice close reduction tried, again failed, and now it was for a open reduction. After that, it has failed again. So now with those many number of failures at that stage, the only option in that time was using a constraint liner. As has been discussed by you also, that this was one of the options, especially when we did not have the dual mobilities at that stage. So this was an option with which we could settle that unstable hip in this situation. Another scenario is that a THR was done in 2007, it was revised in 2014, and it failed subsequent years. So whenever we have got this kind of a situation, we do have to look in for, when we were going inside, we took out all that was implanted inside, now used a dual mobility cup over there and settled with that using the dual mobility cup. This is subsequent follow-up of 2 years. Patient is reasonably okay, stable hip, and able to maintain that thing. There is another situation, again, this was way back in 2010, a hip which was dislocating many times. And every time the reduction was done, it was dislocating after some time. Again, there were not many of the options. That cup was beautifully placed. At that stage, we were aware of something called PLAD, posterior lip augmentation device, that was somehow not available in India from DEPI company. It was not in India. So what we thought, because that cup was very well placed and we were not very confident of doing all big revisions at that stage. So we made indigenous kind of a PLAD. We took a same sized cup, cut it to match over there. And then if you can look over here, we put it there, supported by the K-wire and the bone cement in the back of it. So using that cup of the same diameter, cutting a part of it, trimming to match, fixing with wires, and supporting by cement like this. So creating a kind of a support, and it did work well for next 5 years. So till 5 years, you can see this was the reconstruction, and the person was able to go around. He definitely had a weak abductor muscles, but he was comfortable going around. It failed after 5 years. And at that time, we did reduce it, but this fixation had gone out. So that was the time when we had these dual mobilities available with us. So we took it out and put a dual mobility cup. And with that, now we have got about 6 years of follow-up. The patient is able to do better. Now he's able to walk around. Now it's 6 years. So that was one thing which we do not do it in routine, but at that stage, this was one of the experiments we had done in that situation. Then it is an 82 years old male which was brought to us with a dislocated hip. He was a NRI staying in England, and this surgery was done. At the time, it was probably in 2014 when this came. We were not sure what kind of a implant this is there. We did ask around with the various companies, but we could not really find it out what kind of the implant this was there. So this was a query, but anyway, we opened it up, and what we found was that it was a dual mobility cup which was cemented inside a bigger cup. Because bigger cup was very well fixed. It was a revision in which this dual mobility cup had been fixed inside with the cement. So when we curated the cement out, it was this kind of this thing over there. So this thing which has actually come out, if we go back, it has actually come out in toto from the cement side. So as we went there, so now what to be done? Now he was a patient, 82 years with a very well fixed cup. And this has been there for quite some time. So we repeated the same thing. We used a dual mobility cup and fixed again with the cement inside, just like what has been done earlier also. And we could subsequently get a paper also. We could see a paper also that these things have been tried. So in this case, at least for those 6 months when the patient was here with us before going back to England, he was able to ambulate with this kind of a dual mobility cup cemented within the basic cup over there in that situation. Another scenario, a 40 years old man who had a post-traumatic hip and a cage had been placed there, but within 5 months, the hip has dislocated. Now, to go inside, an attempt was made, reduction was made, which could not be achieved. And now this is the situation. When we went inside, what we found that cage, the anterior part was far beyond, creating a kind of a impingement here. Just like in Dr. Pachauri's, you could see the bony, impingement. Here there was a part of the cage which was lying anteriorly. And this has been creating a kind, so we took this kind of a, cutter over there and cut this part of it, the anterior part of it. And here also we are using osteotome to separate it out. We separated that anterior part so that we could smoothen it out from the front side also. This cage was very well fixed over there, so we could cut that edge of this thing, and thereafter, after freshening it over, we put a dual mobility cup, and this is the dual mobility cup. And after this, we could get a reasonable follow-up, and when the patient was quite okay from this kind of a situation, the hip became a stable hip. Another interesting thing was this patient, a 60 years male with a pelvic fracture, with an acetabulum fracture, which has been fixed in some hospital way back in 2018. It was fixed over there, but then it did not well. So he went to some another hospital where a replacement was done. What happened with that previous fixation and why this replacement was done? But it was somewhere in March 19 when this replacement was done. What happened subsequently? Within 3 weeks, that hip dislocated. That surgeon did a close reduction, but again within a week it re-dislocated. Now in this situation, patient went back to the first hospital where the initial surgery was done. They did a CT workup. They tried to find out any impingement over there or anything over there. And they changed this replacement with a larger head and with the kind of an uncemented cup over there. And this is the fixation which was done. After about 4 weeks, again it dislocated. The second hip also dislocated. And now there is a situation that we all understand that when we are dealing with the acetabulum fracture, the abductors are mostly involved and they are weaker also. They could be one of the factors also in this kind of a repeated dislocation after both kind of a replacement surgery, whether with a smaller head or with the larger head also. Again, they did a CT workup. Probably nothing much was defined as an inversion. I don't know whether we can see that this was highly antiverted. You can see over here. So this could be one of the reasons for, but because we don't have a condylar image in the CT scan, so we could not see it out, but it was worked up done. So when this patient came to us, we worked up for infection. Obviously, we aspirated a lot of altered blood from this area. The CRP was high, the ESR was high, but we could not see any microorganism, no FB, nothing of that sort. So it did not look to be infected also to the CRP. So we eventually opened up. And what was there? When we opened up, we found it was not really infected, but the liner has been placed with the elevated ridge anteriorly rather than posteriorly. So when we rotated the liner to a posterior superior direction, the hip became stable. So this was basically the liner change only. So we took a fresh liner, a fresh head, and placed it in a proper direction with the elevated ridge posteriorly. And then this is that he was subsequently okay in the early 6 weeks period. And even in the subsequent week also, at 6 months also, he was reasonably okay with that kind of this thing. So no further dislocation happened in this case. So it was a kind of a liner change only at that stage. Another case, a situation where there was a primary surgery in May. In June, it was revised again. We don't know what was the reason for, but within a month, this was revised. But that revision surgery also failed in August. Again, it dislocated. So there was some factor which was causing dislocation and repeated dislocation very early after it. And when we opened it up, the stem was retroverted. It was loose. We did not have a problem in taking it out. We just pulled it out and it came out. The cup was loose. We could just pull it out after taking out of the screws also. So once both were easily removed, we did not have a problem. So we just went on a dual mobility cup, and this was quite loose. So we went for a diaphyseal fitting stem over there. And then this was the situation when we could have a patient at a 1-year follow was reasonably okay in his outcome. There could be a problem on the stem side also, where the stem could be loose enough, and especially when we don't have a good abductor mechanism, good containment in the proxipart part, there could be this kind of a situation. So here, after the initial debridement and taking over, we changed both the stem and the cup. And though the lady is still on the walker at a 9 months follow, because we do not have it. So, but she feels more protected, more secured with this thing. The hip and the stem seems to be doing okay. And the same situation again here also, where the stem actually gets, because of the poor purchase into this area, the total lysis around this area, we do that cleaning it up and change it with the, after the antibiotic cement, we next time we change it with the proper dual mobility cup and a diaphyseal stem, and with which the lady is able to manage herself at follow-up of 9 months as such. And this is her follow-up at 18 months. So no more dislocations happening at that level. So whenever there is a early dislocations after replacement surgery, whether it's primary or secondary, there is a factor that probably it is the component which is malpositioned there. And in this kind of a scenario, looking at that very cause, whether we then subsequently change a cup, go to dual mobility, or revise the stem, or revise the acetabulum cup, these are all the factors which can be done in this kind of a situation. Thank you.
Thank you, Dr. Sen. I think the QA will take up during the panel discussion. And may at this stage involve Dr. Vijay Bose, invite him to speak on spinal abnormality in hip dislocation.
Hey, thanks, thanks, Manoj. Hello. Thanks, Rajiv. I don't know if Rajkumar is here. Always a great pleasure to be part of the IAA webinars. I think it's absolutely a fantastic one. So let me just start this one. Okay. Oops. Right, can you see the slides, please?
Yes.
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 Okay, great. So this is a favorite topic of mine, spinopelvic derangement and dislocation. It is a 1 hour talk. It's very tough for me to squeeze 5 minutes, but nevertheless, I'll do my best. The conditions in which risk of dislocation is present due to rearranged spinopelvic alignment, we all know that stiff spine, very common in our country, angst and post-spinal instrumentation, another common condition. Lumbar spondylosis, elderly patients with stiff spine, very important. Structural scoliosis of all etiology. So these are the conditions in which the surgeon has to be careful, because some kind of a stiff spine may cause problems with the hip arthroplasty. Now, whenever you listen to this topic, which is now a very hot topic and it's found in all the conferences, the speaker usually talks about all these formulas, which I'm not sure anyone follows. And then finally, when you ask the speaker many times how he actually works it out in the individual case, he says, I need to, have my laptop to work things out. That's a sure sign that he really is not applying it in his practice. It's just all theory. So today I want to make it very simple, very, very simple, so that even a beginner surgeon can apply these principles in arthroplasty. I think, no point talking theory without understanding. So let's keep it very simple, that even a junior surgeon who's just starting arthroplasty would be able to apply these principles. So that's the focus of my talk today. So the first thing is, today we're going to talk only about sagittal plane abnormalities. For the lack of time, I will not cover all other deformities, only the sagittal plane deformity will cover. So Dr. Ranawat has very nicely described in the AP view how the normal operator foramen looks like. That's a normal cat's eye view. And if you find that if the patient has got lumbar kyphos, then the cat's eye becomes very open. So that's a very easy sign to follow. And you find that there is increased lumbar lordosis, the cat's eye becomes slit-like. And that's been well described by Ranawat. And that's the first thing that you notice, that there's some abnormality going on, and we need to recognize what abnormality and do something about it. Now, we all know about pelvic obliquity, and I think but I think very few of us understand what is pelvic tilt. And the best way, I think, of understanding pelvic tilt is to compare to pelvic obliquity, because we all know about pelvic obliquity, and comparing pelvic tilt to pelvic obliquity, then things becomes very, very simple. So we all know that the trans teardrop line will give you the obliquity of the pelvis, with the horizontal, that is the so many degrees of pelvic obliquity that we know. Now, pelvic obliquity is the one that drives cup inclination and correction. Suppose somebody has got a fixed pelvic obliquity, you need to do something about the inclination, and it's not difficult to work out how you work out the inclination. That's very simple. But in reality, we have to do actually side bending spine view, just to ensure that the spine is not fixed, so that the pelvic obliquity is fixed or not. We rarely do this because it's a very uncommon situation. There is scoliosis, structural scoliosis. Usually spine surgeon operates first. So we almost never encounter this situation. However, the pelvic tilt is what we see in our day-to-day practice. We see it very, very commonly. And this is what every surgeon must recognize, the pelvic tilt. So to make things very simple, pelvic tilt is nothing but a line that joins the center of S1, top of S1, to the center of your hip joint, or center of the femoral head. That is your pelvic tilt. Pelvic obliquity is in relation to the horizontal plane. Pelvic tilt is in relation to the vertical plane. So that's all there is to it. So there's pelvic obliquity, there's pelvic tilt. Now, normally the pelvis is a little posterior tilt, giving all of us a native anteversion. Anywhere between 10 to 25 degrees, we get a native anteversion. That's because the pelvic shows a small, unlike pelvic obliquity, which is straight, pelvic tilt, there's always a posterior pelvic tilt in all of us. The pelvic tilt is what determines version and its correction. So if you want to correct the version, you're looking at the pelvic tilt, just like how inclination would be the one which denotes by the obliquity of the pelvis. So it's very important to work out what's happening, because this has got serious consequences, and how we do it by taking sitting and standing lateral spino-pelvic films, and that's how we work it out. Now, there's only one parameter that's important. There's no need to talk about 100 parameters, only one parameter, that is the pelvic tilt. So normally we said there's a slight posterior pelvic tilt, and that you can see here, and you can find that as the patient is standing and the patient is sitting, you find that there's a migration of the hip anteriorly to the spine, and therefore the line joining the hip and the center of the S1 becomes big. And if you draw a vertical line, the pelvic tilt increases. So from standing to sitting, the pelvic tilt increases. That's all there is to it. So as the patient from standing to sitting, the pelvic tilt increases. Normally we have a slight posterior pelvic tilt, but that increases significantly from standing to sitting. Now, pelvic tilt is a surrogate of anteversion. It's not the same, but almost the same. So all that you have known is the pelvic tilt is your anteversion, the surrogate of anteversion. So if the spine is rigid, what's the problem? So here is a patient, the instrumented spine, and we find that as the patient sits, there's no compensated increase in pelvic tilt, and therefore the established anteversion, and therefore there's a high risk of posterior dislocation, anti-impingement, posterior dislocation. And that's the problem. And that's what we're trying to counter here. So we talked about the pelvic parameter. There's only one spinal parameter, the sacral slope. Sacral slope, nothing but the top border of the S1, which you to the horizontal, that gives you the normal sacral. Normally, when standing, the sacral slope is around 50 degrees, and when sitting, you find that we go into a position of relative kyphosis. So from standing to sitting, the sacral slope decreases from roughly about 50 degrees, roughly about 30 degrees. That's all there is to it. There's no need to remember any other parameter. From standing to sitting, the sacral slope decreases from 50 to 30 degrees. Now, putting both these parameters together, the spinal parameter and the pelvic parameter, in a stiff spine, what we're interested in is stiff spine. So, assuming the stiff spine, you find in this patient, you find there's a large sacral slope here. You can see sacral slope is large. Therefore, the patient is as if he is standing, as we said. And you find that the hip is almost under the spine. That means there is a very low pelvic tilt. Therefore, if it's a stiff hip, this hip is stuck in standing. Now, come to another situation. You can find the sacral slope is almost horizontal, so low sacral slope, and you can find the hip is very much anterior to the spine. Therefore, there's a large pelvic tilt. You can see the large pelvic tilt here. Therefore, if this is stiff, this is stuck in sitting. So that's all that you need to know, whether your hip is stuck in standing or stuck in sitting. Both will cause dislocation one way or the other. Now, once we have worked this out, there are only three questions that you need to answer. Is the lumbosacral spine fixed or mobile? If fixed, is it fixed in lordosis or kyphosis? If stuck, is it stuck in sitting or stuck in standing? That's all that you have to answer. And then what is the compensation? So what you really mean by compensation is that the combined anteversion has to be changed by roughly about 10 degrees, roughly about when you want to give compensation. So suppose you are shooting for roughly 35 degrees in a male patient, you shoot for 25 to 30 degrees. That's your compensation that you're aiming for. So three methods of achieving it. You can, of course, alter the cup anteversion, which we'll be probably be doing because the source is in the spinopelvic parameter. However, you can also compensate in the femoral side. And also, if we have a femoral component that has got versional freedom, you can also use that to give compensation to bring the combined anteversion to where you want it. It need not always be in the socket, because we don't want any anterior, the cup being away from the anterior wall to cause impingement of soft tissues. But the key point is you have to find what the deformity is and make the combined version either higher or lower, as the case may be. You can also compensate on the femoral side. It need not be on the socket side only. So this is typically how we do a compensated version. If there is a version that we need to give, we want to keep the compensated version in between the spatial anteversion and the native anteversion. So we come to two examples now. Here's the case one. You can see how the standing values has been there. Very simple to work it out. So you can see that both these values are given for you to see. Now, as the change in values is more than 15 to 20 degrees, although these are not normal values, the change is more than 15 to 20 degrees. Therefore, the mobile spine. As a mobile spine, you can see it's the Angstborn case, and we'll be led to think it's a stiff spine, but it's not a stiff spine. Once you work out the parameters, the change in value is more than 15 to 20 degrees. Therefore, it's a mobile spine, and therefore, no compensation need be given for this case. Although you can see the entire spine looks fused, no compensation must be given for this case. Now, this is another case. You can see that the standing and the sitting values, and you can see that we always are interested only in the pelvic tilt. The pelvic tilt is 21 degrees standing and 23. So there's a fixed spine. The change is only 2 degrees. That means that's only a fixed spine. But is it stuck in standing or stuck in sitting? The pelvic tilt is 21 degrees. It's much closer to sitting than standing. Therefore, this pelvis is stuck in sitting. And therefore, you must give a compensation by reducing the anteversion. So that's all there is to it. Very simple, work it out. Okay, so we have to give compensation by reducing the anteversion. So again, here you can see, the full length from our spinal colleague. I took this. You can see how the patient is standing as if he's sitting. You can see the high pelvic tilt. The hip is much more anterior to the spine, high pelvic tilt. So he's standing as if he's sitting. So hip arthroplasty in this gentleman would have a high risk of anti-dislocation. So we need to reduce the anteversion. So because of time limit, I'll have to stop here. So thanks very much. Thanks, Manoj, again.
Thanks, Vijay, for making this talk that simple. Still, it's very complex. Thanks, really. Thanks for putting us on right. And we'll take your questions during the panel discussion. May I now at this stage invite Dr. Rajesh Malhotra to give his presentation on abductor deficiency.
Thanks, Manoj. I think
I just
yeah,
I love
yeah.
How do you stop pause? Stop share. Yeah. Sorry about that. Yeah.
So thanks, everyone. We are going to talk about the abductor deficiency, and this is a 55-year-old male who was operated for fracture shaft of femur and then fracture neck of femur in 2016 elsewhere, developed secondary osteoarthritis. Right total hip replacement was done elsewhere 1 year later, and then he came to us after 6 months like this. Now, the question is what to do next, and we know that the earlier failures can be because of infection or instability. The ESR and CRP were normal. Hip aspiration showed a dry tap. And it has now been shown that instability is indeed the commonest cause of failure, about 20.4%, followed by aseptic loosening and infection. And in this seminal paper by Wayne Poprowski's group, if you have a revision hip replacement, the 3 commonest causes of predisposing the patient to dislocation are history of dislocation, abductor deficiency, and complex acetabular defect. And we know that the same group has classified the unstable total hip arthroplasty in 6 types, depending on malposition of acetabular component, femoral component, abductor deficiency, impingement, late wear of polyethylene, and unclear etiology. So coming back to our patient, I just want to inform you or tell you that when you have the right hip, usually the injury or the defect in the or injury to the acetabular abductor mechanism is right here, anterior superiorly. So that's around 1 o'clock, and it's about 11 o'clock for the left hip. So in this patient, when we explored, we found there was a discontinuity of the abductor muscles. We actually did an end-to-end repair. And this was actually post-operative radiographs, and he was actually able to walk quite well. Now, the results of surgical repair of abductor avulsion after primary hip arthroplasty have been reported, and they have been shown to have good or excellent result. The problem is with the chronic tears. When the tears are more than 15 months old, there's a very high rate of repair failure. Obviously, it's not the option for the patients who come to you with an abductor tear more than 15 months after the injury. And then according to one of the papers, it is the dual mobility cup, which is actually pretty useful for such cases with abductor deficiency. So bringing on the second case, 45-year-old male, known case of chronic liver disease, had right total hip replacement in 2012 for AVN, presented with a discharging sinus. Everything was taken out, and a 2-stage revision was done. After 3 months of antibiotics, the ESR and CRP were normal. Hip aspiration was a dry tap. Wound was healthy. So this is when the patient came to us and looked at the level of GT. The stem was an option. I mean, that was a challenge to choose a stem, as well as whether to use a normal or a dual mobility cup. But when we went in, we found this bald greater trochanter. So this had been a long time. So when that happens, as Dr. Luigi said, that you have to consider the soft tissues around hip, and the deficiency has to be managed. It can be managed by muscles around the hip, which can be gluteus maximus, vastus lateralis, or TFL, or it can be managed by lat dorsi, synthetic mesh, or acellular dermal graft, or the Achilles tendon allograft. So the gluteus maximus flap transfer technique has been described quite elegantly by Leo Whiteside, and that is basically decided by the fact that Gmax has dual blood supply, the superior gluteal artery and inferior gluteal artery. In fact, you can use each of these parts separately for transfer, and you can use them as rotational or the free flaps. So in this particular case, we mobilize the anterior half of the gluteus maximus. And the technique is that you mobilize this half. You usually would have split this to go into the hip from the posterior approach. You take the anterior half, you actually do a T-shaped incision in the vastus lateralis, expose the greater trochanter bed here. You can make it raw, pass drill holes from there and pass the sutures and bring this anterior half of the gluteus maximus through this. And then you close these V-shaped vastus lateralis thing on top of that, and you suture that. And that's the complete formation of the sleeve, and that's the patient, that's what he got. And there's a complete restoration of the soft tissue, and this is how he was. So this has been assessed, the role of gluteus maximus flap transfer in 15 patients in this study, and it showed good to fair results at a mean follow-up of 33.5 months. And then the marks done at post-operatively, they showed no evidence of the muscle degeneration. So to summarize, if you land in a situation where there's a malignancy and there's an acute loss of abductor, which means they have been excised along with the tumor, then lat docile transfer or the synthetic mesh is a choice. But in a more common situation, which I'm going to talk about, if there's an acute, if there's a non-acute loss of abductor, but it is less than 15 months, do a direct repair. If it is more than 15 months, you can actually, and you have a mass of gluteus maximus, you can do a gluteus maximus transfer the way I showed you. And if it is more than 15 months, but multiple revision surgeries, and then posterior tissues are inadequate, you can use an Achilles tendon or calcaneal bone allograft or acellular dermal allograft. But if there's a large separation between gluteus medius tendon and the femur, you can actually move proximally the whole vastus lateralis, and that can actually act as a abductor muscle. So to conclude, you must identify the risk factor for dislocation. Dual mobility has been shown to be a good option, whereas the large head is not. Remember that if there's abductor deficiency, large head doesn't help, dual mobility helps. The primary abductor repair should be done in acute setting, and gluteus maximus transfer should be done in chronic condition. Thank you very much for your attention.
Thank you so much, Dr. Rajesh, for putting these facts right. We will have these issues on abductor dysfunction during the panel. And now may I invite Dr. Rajiv Sharma to give his talk on dislocation of constrained liner. And beyond that, we'll have the Q&A and the panel.
Thank you, Manoj. I'll be speaking on constrained liners. Are they a guarantee for stability? And that is probably the most important thing, that if we put a constrained liner, does it mean that this will be the final answer? We'll explore it in the next few slides. So constrained acetabular liners components are for two reasons. One is the patient-related factors, especially in a low-demand patient. In case with an incompetent abductor mechanism, surgeon may choose, these are the two main indications. There are two types, cementless and cemented. The bigger issue is that it should be used as a salvage procedure in a low demand patients, because even if you fix it up in the best possible way, there is a possibility of component pull out, which is a serious risk prior to achievement of the ingrowth, or even in a cemented case. Failure mechanism is basically in three ways. You should understand that cup loosening will be because of the extreme the strain on the whole component, the failure of the locking ring, and the polywear, especially in the long run and especially in the high demand patients. Constrained liners are incapable of meeting the demands of the revision total hip arthroplasty in a younger patient mainly because of the poly failure, as what we see here. Few examples: 78-year-old male, 6 months after failed dislocation of failed prosthesis, dislocation of the hemiarthroplasty, he has been walking on it. The answer is that you put the constrained liner, and this may be able to do well because this patient is not so much high demand patient. Another patient, 80-year-old, fell on the floor, had the fracture of the trochanter on the left side. And this patient was treated with the bipolar prosthesis, and the trochanter was fixed. Because of the poor condition of the patient, is not very strong, he had a fall and dislocated the hip. In this patient, I prefer to do the cemented constrained liner. That's what you see here, and the trochanteric fixation along with this, because just the fixation of the constrained liner is not enough. And then after this patient, because of his condition, his old age and debility, he had a fall again, and he fractured the other trochanter. Now this side, we did not wait, and we did the constrained liner on both the sides. This patient, who's 82, did well with the both sides cemented constrained liners. So in these patients, it is okay to do the constrained liner. Of course, probably in today's time, our first option should be the dual mobility in this kind of a situation. Another very interesting example, the shattered proximal femur, an infection which is not part of this talk, but here you have the abductor deficiency, you have a dislocated hip, you have to reconstruct the proximal femur, the two-stage surgery. We use the mega prosthesis with a constrained liner. And that's what you see, that this patient was able to do well. At 3 months, he's able to walk with the support very well. Could negotiate on the stairs as well. This is the 5-year follow-up. Patient is able to walk well. So in these kind of the low demand patients, probably the constrained liners are okay. Another interesting example, which gave a lot of learning experience. In this patient who had a very unique kind of a atypical giant cell tumor, which was extending the whole of the femur shaft. The total femoral replacement was done, removal of the whole femur. And that's what we see here. The fixation of the constrained liner. Probably in these kind of cases, constrained liner is a good option because you have a significant absence of the covering tissues, the abductors. This patient, 2 weeks post-operative, was able to stand and was walking very well till 5 years, doing extremely well. Was able to walk even without the support. At 5 years and 3 months, he had a fall and he dislocated his hip. This was an acutely painful condition. The failure was because the liner ring was broken and there was a significant polywear because the young patient has probably been using it too much. And that's what we did. We revised the constrained liner, and during the panel discussion, we'll discuss with Dr. Lugizagra and other learned colleagues that could it be that the failure of the constrained liner should we have done the dual mobility? Failure mechanism in this constrained liner was failure of the locking ring. Can dislocation of a constrained liner be treated with a dual mobility? Probably this one of the article which gave very good idea. But here also you had the 3 out of 14 cases who had the dislocation again. So whether the dual mobility can be used in these cases or not, we'll be discussing in the panel discussion. Conclusion is that constrained liners are best suited for elderly and low demand patients. Dual mobility cup may be more suitable option for a high demand patients. Dual mobility may be used for a revision of a constrained liner. Thank you so much.
Thank you, Dr. Rajiv. Thank you so much for a wonderful part. And now we get on to the panel. And I would like to welcome, apart from the speakers so far, the new panelist, Dr. Anup Jurani from Jaipur, Dr. B.D. Chatterjee from Calcutta, Dr. Harish Bhende from Mumbai, Dr. Krishna Kiran from Hyderabad, Dr. N. Rajkumar from Coimbatore, and Dr. Pradeep Bhosle from Mumbai. And Dr. Rajiv, I think the way we will run the panel is that we'll shoot up a few questions to the panel and then we go on to the cases from each of the presenters.
Yes.
And we will first take over the chat box. Before we start through, I have a question for Dr. Luigi Zagra.
Yeah.
Sir, now does head size or neck length make a difference in constrained liners?
Head size and neck length
Yeah.
in constraint liners.
Yeah.
Of course it makes, but in this, with constraint liners, you are really in some way company dependent, because you are, there are not so many options. Designs are developing. The cases, for example, that we saw now is the old type with this ring and the complete elevated rim all around, where there was a huge problem of impingement, damage of the poly, damage of the ring, and then dislodging of the liner. Of course, if you have a bigger head and a thinner neck, and theoretically a longer neck, you reduce this effect, but on the price of thinning the polyliner. So it's a combination of both, of course. If the company provides you, and some of them provide now 32 or 36, of course it's better. But on the other side, you have to consider the neck size, avoid, as mentioned, the skirted heads in these cases. And it's really a balance between advantage and the disadvantages that can be provided by the company.
Okay, wonderful. Professor Rajesh Malhotra, a small basic question I think would like to pass it on to the general audience, which want to know. When you have these trochanters that need to be fixed, what is your preview? What should be the choice? Tension-band wires, some sort of claw plates, or stuff like a Del-Miles plate? What do you think it is the best choice in particular situations for fixation of trochanters?
So Del-Mile plates are great, but they are not available and they're prohibitively expensive. I personally feel, and there are a lot of people like my friend Chandu Thakkar who says that if you put wires around trochanter, you can find them everywhere in the body. He has shown that it travels across in the circulation also. To me, the best thing is non-absorbable suture, which are fixing the escape greater trochanter transosseously is my first choice actually. But then there are people who have described good wiring techniques using the circlage wires, and it has to be transosseous. That's what is important. And that's where it is. You have to go through the femur and fix it well, whether you use the non-absorbable sutures or the transosseous wires.
Why is this question, Rajesh? Shows many times you get late presentation of patients where the trochanter is riding high. Getting on with the tension band wiring is normally not a possibility. So in all those parameters, what is the technical tip you would like to give to youngsters listening to our webinar today?
So you are absolutely right. It is actually, sometimes it has been chronically escaped proximally and it becomes difficult to pull it down. You have to hold the trochanter and do a little bit of dissection to release the abductor muscles, leaving the pedicle intact. And then you'll have to abduct the limb and approximate the trochanter to the bed where it belongs. And then you will have to be careful to protect it in an abductor brace at least for 3 months before gradually bringing it back to normal. And then still there's a high incidence of escape. So there's no easy answers or a ready to use answer for your question. But this is what I would do without guaranteeing that it will stay there forever. So that's why it is now being increasingly said that you should use a dual mobility cup in all these cases. So even if it escapes, that is your best bet against an instability, even if it escapes again.
Thanks, Dr. Rajesh. Dr. Rajiv, I think we should have first the questions in the chat pod before we start on with the panel.
Yes. So there was a question for Professor Luigi Zagra. Does choosing of whether to use a dual mobility or a constrained liner depends on which and how much part of the abductors are dysfunctional?
Well,
Thereby that how much the abductors dysfunction is a decisive factor in choosing the implant?
Okay, thank you for the question, which is a good question, of course. To be honest, for me, it's always difficult to clearly evaluate how much is the damage, because you can have a functional damage sometimes, and sometimes you can have a major surgical damage while the patient is better, probably because of the scare. We don't know, but sometimes there is a discrepancy between the function and the damage that you can see inside. As a general concept, I will try always to use a dual mobility when there is not a complete disruption, especially in the young patient. And another trick is to increase the femoral offset. So increase the femoral offset, remove the source of impingement, and try to use a dual mobility. If I am doing something when I can choose the type of cap, I will try to use a cap that can give me the possibility, in case of failure, to move from dual mobility nowadays, not in the past, nowadays, when there is this possibility, to a constraint directly without removing a stable cap, so without destroying the pelvis anyway. We have systems with this. So when there is a major damage, I explain to the patient, we try to preserve and do for you something that can work for a longer time, such as a dual mobility. If it will not work, we have to move to a constraint in the same system. This is a general concept. But I want, just to underline the point about the AB damage. In the vast majority of cases, it's iatrogenic. So the most important thing here is prevention, because there is not a very good system to repair it anyway. White side technique, vastus lateralis, whatever, they can work, but it's always difficult to restore. So be careful in your surgery. During revision, in revision surgery, don't use approaches that destroy the AB muscles, because they never work when you reattach, not in primary, in revision. And then be very careful with your greater trochanter, especially in case of osteolysis. And if it is escaped very proximally and chronically, we'll say that when the greater trochanter feels the freedom, never wants to be captive again. So don't reattach it. It will not work in the chronic and osteolysis situation. You have more damage by the internal fixation than by the greater trochanter itself. This is my experience.
Right. That's very right, that putting up too much of metal at the trochanter to hold the gluteus maximus, medius, is not enough. Very right. Dr. Zagra, do you use in a case of the dislocation of the dual mobility liner, the head, do you use this, when you have to revise such a case, would you use a constrained liner or would you use another dual mobility?
It depends on the reason of dislocation. If there was some mistake, for example, in the implant positioning, I try to correct what was wrong and go for another dual mobility. If there is a clear major damage of all the soft tissues with a patient which is not collaborative, neurological or whatever, I go to a constraint.
Right. Manoj.
Yeah, any questions so far, Rajiv, that you have in the chat box, or shall we move ahead?
I think chat box is done.
Okay, I think the format will be, we'll shoot a couple of questions to the panel out here, have their inputs, and all this while the gist is to give take-home messages on each subtopic for the audience, and then we'll have cases from each of the panelists. So before we move on, I would have a very basic question for the panelists out here. In the current area, we have discussed about this dual mobility and constrained liners. Is there any condition where you think that the bipolar hip arthroplasty can be a salvage treatment for instability of the hip? Dr. Rajesh, you see a lot of cases with a lot of us where cost is an issue. Do you think at a certain places, there is a place for a bipolar?
Manoj, that's a great question, but there's a lot of literature which has shown that dual mobility fares better than bipolar. A lot of literature there. So I would not say that a bipolar is, I understand it's a cheaper option. It's something which everybody can do and is easily available. But the literature suggests otherwise, and current literature suggests that the dual mobility is far better than the bipolar as an option for, although it's, I can understand where the question is coming from, because both are large head, but the literature has shown that bipolar is not as good as the dual mobility.
Manoj, there is a question probably for Rajesh only. from
Yeah.
Dr. Jagandeep on the chat box. Is using proline mesh a suitable alternative for reconstructing abductor defect?
So
As
those things,
assess the mechanism reconstruction in
yeah.
tumor situation.
Yeah, so that's a great question again. Proline mesh and these acellular grafts and tendoachilles allograft, they have all been described and have been shown to be somewhat effective in acute abductor deficiency, where you end up excising the abductor mechanism. For the cases where it is an acute, like Dr. Luigi said, intraoperative iatrogenic injury, repair is your best bet. But if it is chronic, more than 15 months old, then the literature says it has to be some kind of, the gluteus maximus transfer with or without the iliotibial band transfer.
All right. Thank you, Rajesh. Manoj?
So now, dear masters, so we all have been talking about the approaches and all this while for reducing the instability, the role of different approaches. I would like to know a quick one from each one of you on your workhorse choice. What is the approach? Interior anterolateral, direct lateral, posterolateral, or the very newer version in US, which is the DAA? And would you change your approach for a high distribution group like a neck femur or like we just showed fixed deduction or a stiff spine? So what is your approach that you use on, and would you change your approach in any case? Starting with you, Dr. Pradeep.
Yeah, that's a good question. But most important is you should be friendly with your approach. So that is the most important confidence you get. So I'm very happy with posterior approach, and no situation I need to change. In some situation when there's a fused hip, I use dual hip approach. Otherwise,
Anup, any change to your scenario?
No, posterior always.
Always posterior. So no change for any high distribution group.
Yeah.
Krishna, anything that you want to add up?
No, I think the approach should not matter. You should do what you are good at.
I think that's a wonderful summarization for the audience out here for the take-home message. The historical data, yes, used to show that posterior approach gives you 3 times higher chances of dislocation than an anterior approach, but the current issues that incidence of dislocation with this is much reduced with this posterior soft tissue repair mechanism that is followed. And clinical and functional and radiographic outcomes of this hyperplasty meta-analysis comparing anterior and posterior approach. DA takes a longer time. Yes, it has an early functional recovery, but no significant difference between the two groups in terms of clinical complication-related late functional radiographic outcomes. So the superiority of DA is not there. Similarly, another meta-analysis of surgical approach is not associated with instability after primary total hip arthroplasty, comparing anterior and posterolateral approaches. Conclusion goes the same way, no difference in outcomes. So the summary is surgical approach has little influence in prosthesis instability after primary total hip arthroplasty. That's a carry-home message. Now, this goes on to you, Pradeep. Now, when you get a 25-year-old patient like this is what a lot of youngsters get across with a high riding hip, some sort of a DDH information. What is the step you would take on, or what is the carry-home message or a trick you would give across to the youngsters? You do not want to have instability in these cases. These are high potential groups.
Yeah, so the standard thing is, first thing is good preoperative planning. You see where there's a good bone stock, and this is not a very high riding. So you can definitely bring it to the normal center of rotation and build up a good bone, and you can get away with a good cementless socket and stem. You may not require osteotomy, but if you see there's a too much of tightening, rarely you may require a subtrochanteric, but unlikely in this case.
So Rajkumar, anything you will do in particular to restoring the abductor lever arm?
Yeah, thanks Manoj. Here it is a classic dysplastic arthrophylacitis type B. So here the acetabulum is shallow and the neck wise it is a coxa valga, anteverted, femoral side anteverted. So here the issue is placement of the cup. A lot of talk about bringing it to the native acetabulum, but here if you try to bring it there, then superiorly to build up the coverage, it becomes difficult. So whether a bone loss or a bone graft or an augment. So my preference will be a slightly a high hip center, a smaller cup, medialize it, not to lateralize, very particularly to get your abductor lever arm proper. So medialize with a small cup, little high hip center. And in the femoral side, I will choose in this a modular stem like an SROM, which gives you a leverage to correct your version. So you can rotate this thing. So that will be my choice.
So Vijay, out here we discussed about the high hip center. What is the sort of maximum go off you would be allowing for a high hip center in these kind of cases?
I think it's very simple. Your lower edge of the cup must not cross your teardrop, the upper portion of your teardrop. That is a good rule of thumb that we have. And that seems to work well. Once you start going higher and higher, you may be asking for problems. So you have a good 1.5 centimeters of the teardrop in all patients. So that's the post-op X-ray. You can see how the inferior portion of the cup is not higher than the top portion of the teardrop. So that's a good sign, and this will do extremely well. And this is a combination of using the native center as well as the pseudo socket as well. And this is the ideal way to do this case. A complex case is made into a very simple case. And this is exactly how I would do it as well.
So this was a simple outcome.
One point can I mention?
Yeah, Dr.
Whenever you select high hip center, I think most important thing is to avoid lateralization. That's very important.
Yes, that's a very important message. And up till how much of high hip center you would be tolerating, like in a DDH or other cases? What is the maximum limit? What is the tolerance limit that you would advocate?
Is it Pradeep?
Manoj,
Yeah.
here it is, as Dr. Vijay said, it is like almost 1 to 1.5 centimeter maximum. So that is, you cannot keep on going up and up. So reasonably a good bone, good purchase. But the thing is, try to use a smaller cup. That is the whole idea in a high hip center and a dysplastic hips like that. So your judicial reaming, like Dr. Vijay always says, it's a judicial reaming. So the reaming is so important. So that you don't blow away your walls or the anterior column so much. So try to get a smaller cup, medialize it, and slightly high hip center is a better choice.
Manoj, can I make a point?
Yeah.
Manoj, can you please unblock my video because I can't see myself. So here in a crow type 2 and a type 3, where the high hip has been loaded, so the bone is likely to be good. So I think that is a good point in accepting a high hip center. Whereas if you are faced with a crow type 4, then I think we have to try and go back to the original the hip and do an osteotomy to bring the head down if required.
So now going in terms of the acetabular alignment, Harish, are you now? Dr. Bhende?
Manoj, Dr. Zagra has some comment on.
Yes, I have only to comment one thing more. Be careful in these cases about the femoral offset, because the tendency is that because you are putting down and you have some stiffness, then you go with the shorter neck. This is a mistake, because when you go with the shorter neck, you reduce the offset. Sometimes you have smaller stems, and the problem with these hips about dislocation and instability is more related that you are medializing everything, and then you have poor offset, you have valgus knee, you have some problems with that. So go with a higher offset stem. We use conical stems in these cases, and try to use, for example, a longer neck, because you need to control the femoral offset in these cases. And I think that in these specific cases, it would be possible with the smaller cap to go in the native center of rotation, which is always better. I agree that in some cases we have to go with the slight high center.
But so Raj, we have been taught conventionally on about this elevation alignment issues with the using special kind of jigs, so that our cups at inclination of 45 degree, anti-version of 20 degrees. Vijay gave us a very good illustration to keep it very, very dynamic. So what is your go-to method today? Any sort of anatomical or functional, what would you like for your alignment? Because cup is the most important part for this total hip replacement surgery.
It's Manoj, it is like a combination of multiple things. You cannot rely on only single thing like a jig or anything. So it starts from positioning of the patient. So you yourself, the surgeon himself, has to position the patient properly in a properly on a proper lateral position, make it in the center of the table so that your alignment, check the pelvic rotation, tilt everything preoperatively before starting. Then after perioperatively, it is the multiple things. Again, the transverse acetabular ligament, how it is and where exactly you should locate the transverse acetabular ligament. And then based on that, some surgeons are used to jigs, but I don't use the jig routinely. So like a transverse acetabular ligament itself gives a very good this thing. But nowadays, even that also varies from patient to patient. But majority of that should be okay. But positioning also matters a lot.
So Vijay, would you like to add something on top of it to give it very simple for the audience?
Yeah, the transverse ligament seems to be the best bet. The anterior and the posterior margins are good things provided that no osteophytes on it. So I'm sure you all have heard of the term. 40 is the new 45. So we're shooting for, if you align your lower edge of the cup to the tal, inner border of the tal, you get a radiological 40 degrees, but the perioperatively is 35 degrees. That will be because, the perioperatively and X-ray are not a direct match. The X-ray view is a little different. So post-operatively, you want to be 40 degrees, but perioperatively is actually 35 degrees. That's what we are shooting for. That would be what we would do today.
Good.
Yeah,
So
one small point is, if you use a burr, it's very, very handy.
Good. Any point from anybody before we move ahead? Krishna, would like to add anything, or that's good enough?
I think
Rajesh,
Can I just make one comment?
I think Krishna has to say something first before I'll say.
nothing, sir. You carry on. I just said we can move on now. Everything is covered.
I'll just make one point, Manoj, again, so now the modern cups are the subtended angle of nearly 180 degrees. Earlier cups were not, and that led to a lot of problems. Now most cups are subtended 180 degrees. So if you align to the inner border of the tal, you get the 40 degrees of radiological inclination. So that's a good one these days.
Yeah, Manoj, can I make a few quick comments?
Yeah, sure.
Number one is, I think the range of motion available to the patient at the hip must be examined before operating. And you said all the approaches are equitable. I know the literature says that. But if the patient has too much of internal rotation, then this patient is much more likely to dislocate posteriorly. I would be very happy to operate that patient by a direct anterior approach, because that patient has very little risk of dislocating posteriorly or anteriorly by that. The second thing, as was mentioned by Rajkumar, if you have the dysplastic hips or even bony ankylosis, the cases with spinopelvic deformity, if they are much more likely to dislocate, probably the modular stem are a very good option, because in case it dislocates, then you can always go and knock it out and change the version and go. And third thing which I wanted to say was, a lot of people are covering the spinopelvic deformities these days, but what is often missed is the hypermobile spine. So if the movement in your spine between sitting and the standing is more than 35 degrees, you are hypermobile. And the second thing, which is often not talked about, is the kyphosis, which is not uncommon in Indian scenario, with the tuberculosis and the patient being in the kyphotic spine. And in both these situations, you should be given less anteversion and the less abduction angle than you would do normally. Thank you very much.
Wonderful. So I think the carry-home message is TAL is a very important landmark. It gives you a very good ideation in terms of the depth of the cup, on terms of the version of the cup or the height of the cup. But still, inclination is one thing it doesn't cover up. And I think Anup will mention about the navigation subsequently, because navigation and robotics still gives you a better ideation of inclination. So this is your TAL and labrum, which is there in majority of the cases, but maybe it's tougher to locate them in a true MI approaches. But labrum and these things are there. And today we talk about the new functional alignment, and all this is a safe zone. Linux zones is an outdated concept, because today instability following THA is multifactorial and no implant position guarantees stability. So the literature, cup position alone does not predict risk of dislocation after total hip arthroplasty. And the vast majority of THAs within the Linux safe zones for acetabular compensation are there. So there is nothing like a safe zone as what was intention. So now moving on to Dr. Pradeep Bhosle, this is your
Before you move, Manoj, there is a question that basic question that how to take a lateral view of the spine in a sitting position.
I think Vijay should answer that.
Vijay should be able to.
Why you just make the patient sit in a stool and then you shoot the X-ray?
We are currently doing this study. We have completed about 400 patients, So all these patients with stiff spine or stiff hip, we do preoperative standing and sitting X-ray with a special mode which we have taught to the technician. So it's very useful.
So the question from the audience is that what will be the easiest way for them to just make the patient sit on the stool and take a side view, lateral view?
Yes.
Yes. So you want the angle of hip flexion to be around 90 degrees. That's what you're shooting for. The height of the stool must be sort of either 90 degrees of hip flexion. And that's what, I mean, some people cannot get to 90, but those are all exceptions. Yeah.
Anup, you have a comment on this?
Yeah, it has to be a high stool because the gantry does not come down on a normal stool. So you can't have a 2 feet stool. It has to be a higher stool in which
That's
the
true.
sits at 90 degrees so that the gantry actually comes and shoots through at 90 degrees.
So just a quick comment. I agree with what Anup and Pradeep have said. So that's really a cheap and effective and working method of doing it. But you can also do it by EOS. We have EOS, and that can actually not only take an X-ray in sitting and standing position, but can also do all the calculations and give you all these spinopelvic parameters if you like.
But that's exclusive. I think only you can have it. But I'm just telling you that if you have a thigh and spine distance 90, with a stool, you can do it. We are doing it. We have completed 400 cases with a routine X-ray machine.
Sure.
Yes, Manu.
Yeah, Pradeep, this is your case. Would you like to run it forward?
Yeah. So basically, this patient came to us. Hip was fused 2 years ago. I mean, THA was done 2 years ago, and he presented like this. So basically, there was a discharging sinus. That's a separate issue. But my point is, whenever there are bilateral fused hip, both hips should be done, whether you do simultaneously after 1 or 2 days. Unless you do both the hips, it is not safe to mobilize. That's my message. Otherwise, you get this kind of problem. So this problem is purely because other hip was in external rotation, fuse, and not operated. And before that, he was mobilized. So that's an unsafe position. It has caused extra load on the hip and probably the, I don't know, the cup position. So this required a revision.
Pradeep, I think the cup position also is quite not just
So but it was there for almost a few weeks, and so we had to do 2 stage, and he's fine now. So message is bilateral fuse hip, do both side, and then only it is safe mobilization.
Yeah, I think Pradeep's point is very important. So we talked about inclination and version. So the third thing is rotation.
Yes.
So we have this rotational third plane. And if we don't take care of the other hip, we are asking for rotational problem, the third plane problem. Yeah. So you have to take care of that. The only way to take care of that is doing the other hip.
Okay. From this one, I think let me have Vijay speaking. Vijay, you speak a lot on this ankylosed hips. Now, if a patient has one side in adduction, one side in abduction, what is the message for youngsters? Which side should be done first and why? And second thing is there any sort of compensation you would like to keep on these kind of hips?
Well, this patient obviously needs, lateral standing and sitting films. But assuming that we had a mobile spine, we'll assume he has a mobile spine. And then generally, it is you should not operate on a high side hip. If you're not operating on the low side hip, with the high side hip are always with the reduction deformity, they are prone for dislocation. So if it's not if both hips are equally affected, then I would certainly operate on the low side hip first, especially when I'm giving a gap, and then only I'll choose the high side hip. High side hip, as a rule, is more prone for dislocation.
Right.
That would be
just a quick comment, Manoj. If you are going by posterior approach, then it's logical to do the low side first because the abducted limb comes on the top and it's easier to position it on the table in the lateral position compared to trying to put a fused abducted hip lower down. We have seen fractures in the femoral neck when both sides were abducted and we used to put them in the lateral position. Now we do all such patients by the direct anterior approach. But then what Vijay said is right, but my reason would be that when you put them in lateral position, it's actually better to put the adducted side below and abducted side on top so that you can easily access it.
I would like to make a one.
Hey, can I ask you a question? Why do you think the abducted hip or the high side hip dislocate more than the low hip? Can you explain that?
The adducted hip. High side is the adducted hip, adducted hip. Yeah, that will dislocate. But it's open. The cup is open because you have the other hip deformity is there. So the pelvic is going to be oblique till the other hip is going to be done. So the inclination is going to be high. Although the spine was mobile, we'd keep a native inclination for this patient. So you'll have a very open cup and an adducted deformity. You already had a pre-op adducted deformity. So this is a recipe for dislocation.
Now, so this patient is an ankylosing patient. So I presume that because both hips are ankylosed, he's also going to have spine and pelvis also ankylosed, because that has to ankylose before the hips get ankylosed. So this
not necessarily.
In the pelvis.
Patient with a mobile spine like this, but you have to do X-rays. You have to know guessing that you need to do sitting and standing spinopelvic films. No escape from that.
Yeah, but if it is a fixed obliquity, then you anyway have to give a little more inclination on a hip which is adducted to the cup, so that the cup doesn't remain horizontal, and you have to give less inclination on the opposite side.
Yes,
which you will anyway give. So why should it dislocate?
What I covered on the thing, that's a different scenario you're talking about. You need to do lateral bending films for, if there's a scoliosis to see whether it's a mobile scoliosis or not. Just like how you work it out. If you make out that on lateral bending films, right lateral and left lateral, there's no difference. It's completely fused in that axis. Then I agree to what you say. It doesn't make any difference because you're going to give compensation in inclination. But otherwise, it's very rare. This is most likely we will not be giving because most of these patients, the scoliosis is secondary to the hip pathology. When you talk about pelvic obliquity in 95% of patients, so usually we do not give compensation. But as Harish said, in that particular situation, when you have a fused spine with a fixed pelvic deformity, you will have to give compensation. So the side does not matter. You can choose whichever side you want.
So Dr. Malhotra would like to add upon to the fused lumbosacral spine, because normal people would not get the standing sitting views. So in a simplistic parameter, what is the carry home message for these? What sort of compensations you would cover on the cup if you have a fused spine like this and you want to do it?
So I think the point has been made. If the spine is mobile and you are operating on the higher side, you keep the cup more vertical because the pelvis will eventually become square and the anteversion will reduce and the cup will become more horizontal. However, the situation which you are talking about, where there's a bony ankylosis and fused hips, either the patient can stand or the patient can sit. He can't do both because we know that the spine is fused and the hips are fused. The patient cannot bend forward. In those situations, you have to treat it like as if you are treating the apparent limb length discrepancy, because nothing is going to change after the hip. The pelvic obliquity will not change. The spine compensation is not there. That's not going to change. So classically, if this hip is fused in the X-ray which you are showing, I would like to put the cup more horizontal here. Whereas if the spine is mobile, I would have put it more vertical here. So that's the difference between the fused and the mobile spine. In this particular situation, nothing will change in the spinopelvic parameters. The spinal obliquity will not change. So the right hip will have to be a little more vertical cup, and the left hip will have to be a little more horizontal cup.
So the take-home message for Vijay, I'm going to summarize your points for the normal audience. So normal pelvis would tilt anteriorly in standing position and goes back posteriorly, thus increasing the anteversion. In a fused spine, as Vijay said, it happens in a reverse. So in a picture, which is the most common scenario in fused spines, you have a hypolordosis or posterior pelvis tilting. There, the cup is open and anteverted, and you need to compensate that. In all those spines which are hyperlordotic with anterior pelvis tilted, you have a position of the cup which is closed and retroverted. So again, that's where you need to give a compensation for. Now, Krishna, this is a question for you. Does priming of primary total hip arthroplasty prior to or after lumbar spine fusion have an effect on dislocation and revision rates? If you have a patient who requires the lumbar sacral fusion as well as a total hip replacement, which one will you do first?
I would want to do the hip first, but probably it's a better idea to correct the lumbar spine first and then do the hip, if you didn't want dislocation.
So let me just say what he has said is right, but the current thinking is if the hips are fused, the hips have to be done first. And then you should keep in mind that the spine surgery, when it is done, will restore the normal lumbar lordosis and the normal parameters. And that's what our spine surgeons do when they're operating on the spine. So you should put the cup accordingly. But a fused hips have to be operated before anything being done to the spine.
Perfect.
But I assume your question was related to degenerative spine pathology. I think this paper refers to degenerative spine pathology. In a fused hip, there is no doubt that you have to again see if the forward gaze is okay for the patient, then you operate the hip. If his kyphosis is so severe that he can't see in the front, then probably we'll do the spine first, followed by the hip.
So the patients with prior lumbosacral fusion undergoing THA are a significantly higher risk of dislocation and subsequent revision compared to those where THA is done first and followed by delayed lumbar spine fusion. So in those cases, THA has to be handled first.
Manoj, excuse me, it's just not lumbar spine fusion. It's if it's lumbosacral junction is fused.
Yeah.
Junction, just not lumbar spine doesn't matter as much as lumbosacral junction.
Lumbosacral fusion.
If lumbosacral junction is fused, then they are at high risk of dislocation, not just lumbar fusion.
Yeah. So Pradeep, would like to take this case forward?
Yeah. So this patient, he was operated in New York. Basically, these are the first simple, there's a loosening with infection. First stage surgery was done, removal of all the infection at New York. And they did ETO, and this was the fixation. Cup was well fixed with the bone graft after healing of the infection. And this was the final surgery. Everything was stable. But progressively, over next 6 months, patient came to us with this position. Go to the next, please. Within 3 months, there was no discharging sinus. Yeah. So you can see there is no sinus for last 4 months. CRP 12, ESR 46, shortening of 8 centimeter, nil neurological, medical comorbidity. He is a chronic alcoholic with chronic liver failure. And this is the entire ETO was collapsed. And the femoral stem has completely rotated over a period of 3 months. And this is the exact picture with the stress X-rays, abduction, adduction. And so we use a long stem, rib stem, interlocking, bone grafting, and stimulant beads. Next. And this was a stem which was not Wagner, some other stem, and all the hardware. Redapt stem.
Redapt.
Yeah.
Was it the loose stem?
Stem was, we had to do some little osteotomy. So it was relatively loose already. It was rotated 180 degree. And we didn't have much problem while removing. So little thin osteotomy, we could disengage the stem from the whatever fibrosis.
So Pradeep, in this case, you could walk off with your large head alone. You did not require an additional level of constraint. Because considering they have still a high riding trochanter, you did not consider any dual mobility or constrained liner.
No, the issue here was the cup was well fixed with the bone graft, and the size of the socket was 40. So there was only one option of 40 size, and which was difficult. So I could manage 40 ceramic head with this debut reef stem, interlocking, good interlocking, and he's stable walking now.
Try to get the 40 head.
Pardon?
Try to get the 40 head from 40.
40 the
because
ASR components which are available, I think. Now they are not available.
This is ceramic. So there was a ceramic liner, and we removed that and put a plastic liner, poly liner. And
you use the same head, huh? Use the same head.
No. I changed the head.
But potty is not available in our place.
Yeah, but I got it. Zimmer, they managed.
So at this stage, Dr. Sen, if you're around, because you showed a case, when would you cement a dual mobility or a constrained liner with cup retention? Okay, he's not around. So Pradeep, would you like to, what will be an indication where you would like to cement a constrained liner or dual mobility into a
it's a salvage option. So where you don't have anything, then that is a probable option. It's a salvage option.
But in a 40 size cup, probably.
I had planned this and I got it on table. So I was fully aware of this.
Okay.
Yeah, we move ahead.
Take-home message for the large head is said, acetabular circuit size, choice of bearing, and minimum insert thickness must determine the head size. And there is no evidence to support the use of head size greater than 36 mm. And 6 mm poly thickness is the gold standard. But with large heads, the downside still is liner wear and taper corrosion. And this large heads negates the need of skirt in most kind of cases. So what does the literature say for the jumbo femoral head for treatment of recurrent dislocation following total hip replacement? So with this, Harish, your case comes in. Yeah. So what you want to say is it's not insurance against dislocation.
That's the statement I wanted to make, because many times people feel that because I got a largest head possible, I can be immune to the dislocation problem, and it never happens like that. That's exactly when you dislocate. Now, don't go ahead till I tell you to go ahead.
Okay.
Don't go ahead till I tell you to go ahead, please. Can I control it myself?
No, you keep telling me.
Can I share my screen?
You keep telling me, I will move in as per you.
Because then you have to wait till I say next. I just want to make one message in this presentation, that when you are dealing about dislocating THR and you want to do revision in that, the most important point before you decide to do any revision is to find out why that hip was dislocating. A lot of the time surgeons feel that, okay, I'll go in, open and see what is wrong. And that never happens, because you just cannot see anything when you open the hip. You need to identify, or at least try to identify, why that hip was dislocating. And unless you don't have the cause for it, as far as your understanding, you shouldn't try to open that case. Involve somebody else who is more experienced, who is more senior, and then get his or the other person's opinion. So I would like to just illustrate few points how to analyze the patient when the patient has dislocation. So this was a patient, lady about 55, 60-year-old. She had this pre-op hip, and the patient has undergone hip replacement surgery. And she had a dislocation after 3 months. Then that was reduced. Then another dislocation after 6 to 8 months. And then it became recurrent. So by the time she came to me, she was already in a dislocated position and almost about 1.5 years down the line. And she had about 3 or 4 episodes, after which probably the patient didn't go back to the primary surgeon and the hip was remained dislocated. Next slide. So this is how she came to me. Now the question is, I need to find out exactly why she could have dislocated, what was wrong with the primary surgery. And unfortunately, I didn't have access to any one of the immediate post-op X-ray, because as usual in India, you don't have all the data. They came with the last X-ray, say the previous one was kept by the previous hospital. They didn't give it to us. So if you analyze this patient, can you go next? If you see that in this case, don't go too fast, please. Can you just go one by one? I'll say next and then put the next button. So if you see the acetabulum is eroded proximally, and because of the prolonged osteoarthritic process, the ideal cup or ideal acetabular edge should have been at this point. And this was not there. The cup has gone, the acetabulum has gone eroded. Next one. This was the damaged damaged femoral head, which was eroding the acetabulum. So next one. This is how exactly the acetabulum was looking today. And this acetabulum, if the surgeon primarily doesn't realize that there is a defect in the acetabulum, he will end up putting the cup where the acetabulum is flush with the lateral border. Next one. So he had primarily put the cup so that the lateral edge was flush with the existing acetabulum border, which has resulted into a much more vertical cup than what he should have kept. Next one. Go next. So that was the inclination, which was almost about 50 to 50 degree or even more than that. And that was one of the reasons why the hip probably was dislocating superiorly. And when we want to correct this, we have to make sure that our cup should be in a proper inclination. It should be more vertical, more horizontal, so that you will get some amount of exposed area of cup superolaterally. Next one, please. Next one. Now, if you want to put the cup primarily, you should have put the cup over that position. So the cup should be at about 40 degree inclined, and there will be some amount of exposed area of cup on the outer side, which wasn't done by the surgeon. But now when you want to go back and put the cup, you must do that. It is usually quite essential in these cases of dislocating hip. You should take CT scan, Mars CT scan, so that you can get actual idea about how the acetabulum is placed. What is the anteversion given by the surgeon? What is the inclination given by the surgeon? And you must ask the radiologist to get X-ray and a CT scan, which involve both the side of cup in each film. Many times they give you CT scan only of one side, and then you don't get any idea about what is the anteversion or inclination with respect to the opposite side hip, if that hip is normal. So you must get a CT scan, and you must ask them to get axial cuts. You must ask them to get a coronal cuts. These are the two cuts which are very important. Many times they are more worried about giving you a 3D CT reconstruction, which is most useless in these cases because you don't get any idea by looking at a 3D CT picture of these dislocated hips. Now, next one. Now, if you see that there is a excess anteversion, you can see the lesser trochanter very well. So that means this cup and the hip is dislocated anteriorly. The primary surgeon has done the surgery by the posterior approach. And in spite of that, the hip was dislocating anteriorly. That means it makes you realize that there probably is something wrong with the version of the either a cup or a version of a stem. And that's where the CT scan will guide you whether the primary cup was excessively anteverted or whether the stem was excessively anteverted, and what to expect during the surgery when you open the patient. Next one. So during the surgery, we could see that the actual version of a cup, next one, was significantly anteverted, and the new cup had to be kept in a proper version because that was one of the reasons was why the hip was dislocating anteriorly. Second thing, next one, the acetabulum superior plastic was completely eroded. This was the plastic. You can see that there was a complete erosion. So after first couple of dislocation, probably the recurrent dislocation has caused that acetabulum to completely erode, and there was a defect in the anterosuperior area where dislocation was very regular, and eventually it remained dislocated when the patient came to us for a second opinion. Next one. And that is a CT scan vertical section, the coronal section. And you can see that the cup was kept little laterally. There is significant amount of gap or a bone medially and a superiorly. Next one. So you can see there is a medial gap. There is medial adequate amount of bone which is there. Next one. And a superior bone also is there. And that is where you understand that when you want to revise this cup, probably you would like to keep the cup little more centralized, a little more superior to get a better primary fit of a cup, and you can incline the cup much more. Next one. So the plan was to get the cup more deeper, more inclined at maybe 40 degree inclination, and to get the orientation right. The transverse section did not show any obvious error on the term of anteversion in this particular patient. This patient didn't have any spinal problem. There was no fused spine. She was otherwise quite mobile. It was a primary arthritic hip. You can see on the opposite side that hip is arthritis. That surgery was not done because primary surgery kept on dislocating. So we didn't have to worry too much about the spinopelvic issue in this particular patient. The issue was the malorientation of acetabulum by the primary surgeon and malorientation of a femoral component. So if you correct that, most likely you should get a right orientation and right solution. Next one. So when we plan the surgery, we could do with a almost primary cup because we had adequate primary medial and superior bone. So the primary fit was very good. We got a good anteversion, and the stem was also changed to a improved version properly. So this hip eventually stayed very well. We had almost about 3.5 year follow-up. She was very comfortable. And the point I want you to take home is that when you start dealing with treating the dislocating THR, before you open the hip, you must have a clear-cut plan in your mind exactly what is probably the cause of this dislocation and can I correct the cause? And if I have to correct the cause, what things do I need? Do I need some special implant, some dual mobility things, or you want some constraint design? In this particular patient, although I kept dual mobility, etc., but I was quite sure that I probably could get away with doing a properly done a primary stem in this patient, and that is where we could get out of the situation. Next. So this was a proper inclination. I like to keep inclination at about 40 degree because usually the surgeon manually can make an error of plus minus 5 degree. So even if you aim for 40 degree inclination and you can base that on the position of your bony landmarks. So if you have got a CT scan, if you study them well, you know exactly how the cup would look if you put the edges of a cup with respect to the available bony landmark which are there. So this 40 degree inclination and adequate anteversion should be able to deal with most of the cases with recurrent dislocation. Next. Thank you very much.
Yeah. So next presentation is from Dr. B.D. Chatterjee. Dr. Chatterjee, are you around?
Yeah, very much. Can you hear me?
Yeah, we can hear you.
Hello, everybody. So I'll just go through this very briefly because we're getting on, I think, in time. So this was a 70-year-old, rather frail lady, and she had a fracture of the intercapsular fracture operated 6 months ago somewhere. And she was able to walk with a walker. Then she had 2 episodes of dislocation of the operated hip when she tried to give up the walker, treated with close reduction, but did not succeed and presented with 1 more episode of dislocation. So can we see the next slide? Yeah. So this is what she came with. I think it opens up a few questions that particularly in, frail 70-year-old, is it a better option to go for a bipolar hemiarthroplasty sort of treatment instead of going for a THR? And if at all, if you're going for a THR, is it wise to go for a dual mobility hip straight away from the outset? If you look at this X-ray, you will see that the patient that the surgeon has used the longest available neck. So obviously there is a lengthening on the affected side, and that is probably suggestive of the fact that the soft tissues were quite lax to start with in the first instance. So as was very nicely pointed out, that we really must make a diagnosis as to why this was happening. So keeping that in mind, we undertook the CT scans. Can we see the next slide? Yeah. So this was just to describe the patient asthenic. The hip was relatively painless. The CT scans did not reveal significant malposition of the components. And intraoperatively, there was a significant soft tissue laxity in spite of the long available neck that had been used. Can we look at this? Yes. So this is the CT. As you can see that the acetabulum was reasonably anteverted, and also the inclination was also fairly okay. So there wasn't really anything very grossly wrong with the acetabulum. The next one. And when we opened the photograph on the left hand shows the shuck test being done, and you can see the head is coming out quite significantly from the socket, even with a slight traction. So the options here that what we could have done was, of course, that we could have revised the stem and given a wider offset, because obviously we can't lengthen it anymore. The other option, however, what we decided was that because this patient otherwise was a low demand patient, so we decided to just go the simple way and change the liner into a constrained sort of liner. Next one. Next, yeah. So the stem was very well cemented and completely solid. So there was an option to revise it to a high offset stem with a cement in cement technique. But eventually we decided to retain the stem and just change the liner to a constrained liner. The procedure became much shorter and simpler. And well, fortunately, the patient has not had a dislocation over the last 2 years of follow-up. The next one. Yeah, so this is the post-operative X-ray. So I think the message here is, again, that it's very important to make a diagnosis as to why the dislocation was happening. And it is perhaps also wise to do as simple a procedure as possible that is more likely to succeed. We obviously have so many worries and problems with the constrained liner, but I think if the components are well aligned and very firmly fixed, and if the patient is asthenic and not a very high demand patient, I think it definitely has a role. So I would like to open this case out for expert opinion.
See, wonderful presentation, but do you think that ultimately if she was around 65 years of age with a soft tissue laxity, you would have considered something else, or still you would have gone with a constrained liner in this?
See, the other thing what one can do here is an osteotomy of the greater trochanter. Do an osteotomy and distalize it and tighten it. So that's another procedure that can be done. The other option, see, I do not think the acetabulum was the acetabulum probably doesn't need to be revised. We could have possibly revised the stem by using maybe a modular kind of a stem like an SROM and using a wider offset, and maybe change the version, played around with the version a little bit. But I thought this was a simple way out, and it seemed to work.
So any questions from the panel?
I think this is the best option. When you have well osteointegrated cup and dislocation with well-oriented components, you have to go a constrained liner over dual mobility. There's no reason to go to dual mobility straight away. Unlike any other case where you are revising the cup, that's a different scenario altogether. When you have good oriented components, little older patient, lax patient, this constrained liner is your first line of choice. It is not throw away constrained liners, please.
Vijay, why not do just the trochanteric osteotomy, advance the trochanter and just tighten the soft tissue, because the laxity is the only issue. The alignment of components is normal. So why put a constrained device? Because this is going to get constantly going to get problem. She's 65. She's going to be around for the next maybe 120 years to be active. So I'll be a little apprehensive about putting a constrained device in an active person, 65-year-old, when I can get away with just adjusting the soft tissues.
So I think
they're presuming the soft tissues are lax. You can see the head is gone in more lower. The stem is gone lower than it should, and things like that. There are minor surgical errors with the compound that result in a dislocation, and so that has to be addressed. Not a question of just soft tissue laxity. When you open up, the tissues will appear lax. In any dislocation, the tissues will appear lax, but that doesn't mean that was a primary problem. They are a secondary problem.
Manoj, can we have the opinion of Dr. Luigi Zagra on this?
Yes.
I'm not happy to use this old type of design of constrained liners in a case like this. It depends really on the patient's activity, and maybe that the cement within cement technique of the stem with the better head-neck ratio and the higher offset can be solved the soft tissue problem. While I'm not happy in doing trochanteric osteotomy because difficult to manage, the risk of complication is so high that if it fails, there is very poor possibility of solution. This is my opinion.
Because the primary reason for the dislocation was probably the lax soft tissues and the reduced offset post-operative.
Yeah. So this was a debut implant, so we didn't really have an option for a dual mobility socket here. Then
this is a C-stem.
Yeah.
9/11 taper.
No, we would have had to take out the acetabulum and gone for a dual mobility socket there, but that's why that was one of the problems here. Whereas it was a simple procedure just to change the liner.
This is too small for dual mobility.
And probably the cup size was very small. What was the size of the cup?
Very
Looks like a
honestly, I don't
46.
remember.
Looks like
It
a
was
46.
small, yes. It was, I think it was 48. 48.
What about the antiversion of the stem also? It was correct?
Yeah, that was all right. The stem
Yeah.
antiversion was okay. But the longest neck length had been used. The
As
only
Dr.
other
Vijay
option
pointed
was,
out, the stem
yeah.
has gone too much inside. It's like a iatrogenic error. The choice of the stem and the position of the stem is the one which has caused all this problem, particularly in the neck of femur fracture. Already the soft tissues lax, and apart from that, this has been created by sinking in the stems too much. Probably avoided, issue would have been avoided, the dislocation itself. So now the question is whether to change the implant or not. So that is the only question now. So this is also one option, but maybe we have to wait and see how long this survives.
Manoj, for the younger colleagues, our suggestion is that take the fracture neck femur in a very serious way, because fracture neck femur, the capsule is normal, and that's why the possibility of dislocation is much more. And here probably the more carefully the maintaining the offset, using the right type of the implant, right orientation is very important.
So I think that's
how many of you would have just done in the first instance, just done a bipolar and not a THR?
What was the age of the patient, Dr.
70.
70 again is not very old to
active patient to do a dual mobility as a first choice.
My feeling is that if you do a THR in a fracture neck femur, choose preferably a dual mobility.
For all cases?
For all fracture neck femur. If you have to go for a THR.
Not necessarily. That would become dual mobility. Female patients, older patients, small socket size. That really is the key. Small socket size, 44. Then you would go dual mobility, but you get a 36 head, good patient, muscles. Then I think a standard THR would be fine.
Right.
So I think, Rajiv, the message we want to convey is this: constrained liner has to be used sparingly, and the absolute indication in our practice is proximal femoral replacements, as you showed the few cases, as well as abductor dysfunction, because they have a couple of failure modes also on the dissociation part, on the impingement related wear and loosening. And these kind of pictures are not very unfrequent, even in instability cases, to get on. Also, a point for the younger audience to remember is that even constrained liner does not prevent your Trendelberg limb. If you have abductor deficiency, you need to cover up something, because constrained liner would not cover onto that limb. So Krishna, this goes on to your next case, which would answer a lot of other variants to what has been discussed right now. Would you like to take it forward?
Yeah, thanks, Manoj. So this is a 65-year-old man, and we inherited this case somewhere down the line in his history, and we ourselves had quite a significant tough time dealing with this problem. So this man was operated 15 years with this sort of a hip, and he was managed for a late onset instability by polyethylene exchange, and developed recurrent instability following the revision. So they just did a liner and head exchange at the time of revision. The primary surgery was done elsewhere, and the second surgery revision was done elsewhere. And he came to us with 6 episodes of dislocations in a 3-month period. So can you take it to the next? Yeah. So at that time, around 7-8 years back, we had access to the dual mobility from Evolutis. This is a non-modular dual mobility cup. So this was a AML stem which was very well ingrown, and this had a 9/10 taper. So there was no opportunity to put in a large diameter head. The largest you could put was a 28 millimeter. So we made a choice to just do the cup revision, and we revised it to a 58 dual mobility after explanting the socket. The previous socket was 56 Duralock. And the patient seemed to do well, but the cup did not ingrow. Apparently, he sustained a fall, probably because the cup pulled out, and presented to us with this sort of a picture. And we were still a little bit not keen on revising the AML stem, because it was too well ingrown, and it's a messy thing to go and revise this stem. And when we went in this time, there was obviously we ruled out infection all these times, and we went in, we found a superior defect in the acetabulum, and this time we revised it to an augment with a cemented dual mobility cup. Again, the patient was okay for 3 to 4 months, and this time he came back with the other mechanism of failure of dual mobility, where it disengaged from the trunnion, because the trunnion had become so bad that the head disengaged from the trunnion. And this is one challenge with these 9/10 tapers if we retain them after several years. So now finally we had to go in and remove this stem and revise it to a long distally fixing device. The augment and cup were well ingrown, and this was done around 5 years back. So as far as I know, the patient is doing okay at this point in time. So one must carefully assess whether isolated liner exchange may be a solution for late instability, because in instability, instability is the cause for revision, then the risk of failure is also very likely to be because of instability, though something more must be done primarily. And a 28 mm head probably was not adequate for this particular patient. Retention of well-fixed femur also must be assessed carefully, especially it is a tricky thing to revise some of these fully porous coated stems which are well ingrown at 15 years. But the 9/10 taper, which was part of AML A+, must be considered. And it has been seen that there can be trunnion related issues if we retain these stems after 15, 16 years. Sometimes the trunnion can fracture as well. So careful assessment using the Goldberg criteria to see how the trunnion is, whether it is damaged, whether it's crashed or something, is a criteria which is used to decide whether we must retain the stem or remove it. Large diameter uncemented dual mobility may have greater frictional torque, so it may be better off using modular dual mobility in these, although there is a slightly higher risk of the metal liner induced wear, which you must weigh against the use of a non-screwed component in revision, where the bone stock may be inadequate to support large diameter cells for primary ingrowth. So modular dual mobility would have been a better option in this particular case, and probably a better assessment of the stem and the primary revision of the component also would have been an option.
But this stage, Krishna, I have a small question for you and Professor Luigi Zagra, and that's that in your practice today, where is the role of cemented dual mobilities?
Yeah, so my practice, I use cemented dual mobility whenever I'm using a cage for revision or a T-Mars type of shell in my practice. I would cement a dual mobility into that. I would always use a sort of a support mechanism while using these cemented stockets in younger patients with high risk for revision. A very old patients, sometimes we can use it as a standalone device, because metal-backed cemented cups have traditionally been shown to have inferior outcomes in the midterm. So I would not use it in very young patients as a standalone construct. I would use it as a conjunction to the revision shell or the cage, wherever I'm using the cage.
Professor Luigi Zagra, any comments from your side?
I basically agree. I use a cemented dual mobility in a cage as in a well fixed cap when I can use it if it's big enough, just to move to a dual mobility construct, cementing it inside. I know that there will be probably in the future an increasing use of that, but we don't use cemented primary dual mobility caps. We use cementless. But the reason here is more than for the greater functional torque, because this generation of monoblock dual mobility caps have very poor outer surface. They have very poor primary stability. So we never use in revision, where we have poor bone stock or poor bone quality. We always use dual mobility with modularity or cages when we cement the dual mobility liner. And we know from the literature, there's plenty of literature demonstrated that isolated liner exchange is a problem for instability, and you have a high risk of revision. So if you are not able to increase the head size and decrease the leg length with the new head on the femoral side, be extremely careful, because the number of dislocation is huge. I agree with the speaker.
Professor, would you be commenting, do you have the availability of these anatomic dual mobilities in Italy?
Which one?
The bottom one, the anatomic, which has anti-impingement.
ADM, Striker ADM.
Striker ADM.
No. I don't have this vision.
So Vijay, would you like to comment on anything, a single liner on anatomic dual mobilities?
Yeah, I think there's a role for them. Many times, when we use this MDM in younger patients, we have a worry about the metal ions. So when I have good bone stock primary patients, I would like to go monoblock. And if I have the same system, it'd be very handy for me. So an ADM would certainly add to my armamentarium, although we don't have it in India currently. The one point that I want to make about the previous presentation is that late instability is always wear induced. And any wear particles, whether it is metal on metal, poly, or ceramic, will cause soft tissue, laxity. So you must go dual mobility in late instability. No question about that. You cannot do just liner exchange, as Dr. Zaga said. There is something else going on there. Late instability is something else going on. It is even though if we find site malposition of the components and try to correct it, that's not the answer. You need to go dual mobility in a late, unlike the case that Harish showed. Early dislocation, component malposition, if correct, you may get away. Late, you need to protect yourself with the dual mobility.
And Vijay, what do you feel in your cases? How many times do you get this iliopsoas impingement? Because a lot of in thing now in the Western world, talking of the iliopsoas impingement.
Yes.
For you.
We try, certainly in primary, we would never leave a cup with the anterior lip exposed. Certainly not. Even if there is an anterior wall, displacer, etc., we would put it inside the anterior wall and do whatever compensation that we have on the femoral side. In revisions, we try our best to do that, but in many cases we cannot. The anterior lip will be exposed, the anterior margin of the cup will be exposed. Then we just have to hope for the best. But it is a problem. Patients, I have seen patients complaining of that quite bitterly.
So the take-home message for dual mobilities is combines the principles of low friction arthroplasty and with a large head advantage, greater range of motion, better head to neck ratio. And it's a successful majority of studies to reduce dislocation to less than 1% in primary THA. But still, intrapelvic dislocation remains an issue. As Vijay said, with the modular MDM, there is issues of corrosion at the modular metal diabetic, this dual mobility liners. And long-term results in young patients are yet to be seen. So that's where I think it's still a gray zone, whether to use it for very young patients or no. So, Rajkumar, would you like to start in your case?
Okay. Good evening, and thanks Manoj and Dr. Rajiv for this opportunity. So this patient, he will be somewhere around 33 years old male. And in 2013, this patient came to me with the pain in the right hip. And that time when he came, this was the situation. So 8 years post THR. So in 2005, this patient underwent a total replacement that time. Probably, I think it was for a fracture neck of femur, but the situation was like this. So when this patient came here to me, patient had a lot of pain, and that time, I was trying to move it, Manoj. Okay, can you move to the next slide? Yeah. So this patient, that time, the femoral side was well fixed, and it was a very, very old type of stem, and it was not at all an issue at all. So I didn't remove the stem that time. So that time only the acetabulum side was revised. So that time I used a anti-protrusion ring, the Muller's ring, and with a lot of bone graft and cemented, because that stem, as Kiran was telling, that stem was able to take only a 28 size head maximum. So I had to use a cemented poly liner with this cage to avoid the bone deficiency. That time I didn't have the option of this highly porous cups. So 15 years after the index surgery, that is 7 years after the acetabular revision, again the patient came to me with a lot of difficulty in walking. So that one issue was pain mainly due to instability, that he was having a typical, very atypical complaint that whenever he's trying to bear weight, he was feeling something is moving inside, and he was very uncomfortable, and it was also painful. So he felt the head was subluxing on a particular movement, so unable to walk pain-free. So I decided that there is a lot of some instability going on. So this time we have to revise the stem as well. The cup side, I had to see how the poly is, whether the poly wear has happened, or so already twice revision, twice surgery has been done in this patient. So planned for a revision. Next slide. So Manoj, go back. can you just stop sharing for just a minute? I will show that video. I was able to trace that video. So can I show you just a minute? So this was a perioperative video. So this, as Dr. Vijay was also telling, the abductors were very weak. So much of laxity, soft tissue laxity was there, and no way we can adjust this with a head increasing the head size, because already in that first instance it was a longer head, the maximum head available. So in this scenario, no way we can retain with it. And the cup side, even after 7 years, there was no polywear. The cup was well fixed. There was no signs of any loosening. So I didn't want to change the acetabular side, because if you want to do any dual mobility, we have to change the whole acetabulum side. So what I did was I did an ETO, removed the, still after 15 years, the stem was well fixed. I had tough time removing the implant, femoral side. So I had to use all these things. I had the explant system for the cup side, but removed the implant with the ETO, and I went in for a distal loading stem here. And obviously I was able to get the offset correct. And also what I did was this, anchored the weak abductors to the stem. And after that, the hip was very much stable. So the cup was retained here, ETO for the stem removal, femoral offset achieved, abductors anchored, and a distal loading modular stem. So Manoj, you can start sharing. Sorry for the delay.
You can load your present case now.
Manoj?
Yeah.
Yeah.
I think
can you show that your presentation?
I think the next, let Rajiv start his next case, and then we have Anup.
Sure. Manoj, you have the, are you going to share the screen?
No, you start your screen, yours and Anup's.
Okay, so then maybe Anup can go on, and I'll just find it
Anup,
out.
you can start up.
Anup is not there.
Rajiv, are you able to pull on?
Yeah, because I thought that you were showing cases. Yeah.
You want me to try?
Yeah, if you have this my presentation, because you have it.
Yeah. Okay.
If you can start that.
Yeah, Rajiv.
Okay, so we'll be quick, because I think this is the time is really short with us. This was the fracture neck of the femur, basal fracture. Next one. The prosthesis was done. The THR was done. Cemented stem and cementless cup elsewhere. Next one. And the patient came to us with this fracture neck of the fracture, periprosthetic fracture. Next one. And then we do use the solution stem, and this was patient was doing well, was able to walk. Next one. And interestingly, there was a proximal osteolysis, because the solution stems, I'm sure that most of our colleagues have seen this kind of a situation where there is a proximal osteolysis in a well-fixed, distally well-fixed solution stem. That's what we saw in this. Next one, dear. And that's what you see that during the process when the patient was walking, he had a fracture. If you can go back, Manoj, that's a very important one. There was a dislocation before this.
I think that slide is blocking up. It's not coming.
Okay, so this patient had a dislocation before the stem broke. Next one, and then obviously this has to be removed. Next one.
I think that's why I was not, there's your file shows some corrupt data. That's why I wanted you to get it onto yours.
Okay. So just give me 1 minute. If Anup is there, maybe he can talk about it. Otherwise, I'll open up.
Otherwise, yours is the last presentation.
Oh, all right. Then I'll be very quick.
In the meanwhile, any questions from the panel? This is a very simple, I think, a message you need to convey across, because many times when patients come across with a dislocated total hip replacement, what is the right way to do a close reduction? Now, that's a very baseline, but extremely pertinent. Vijay, Rajiv, are you able to get in, or shall we move ahead?
I think, Manoj, you mentioned about the single most message which you should give to the audience who are relatively, less experienced in arthroplasty or hip replacement surgery. And I think the only thing you have to take back home is to make sure before you open that dislocating hip, find out the cause as much as you can. And you must have planned how to correct that cause. Whether the cause is because of any mechanical issue related to the implant, then you have to be in a position to change the implant and revise the implant, and you must have options available. If it is a soft tissue, you must have been able to correct the soft tissue by either a soft tissue surgery and getting some constrained devices or a large modular implant like dual mobility implant. So getting the cause of dislocation before you open is extremely important.
Yeah. Very important message. So, hey, Harish, as I asked a question, Vijay probably didn't get in. So, what is the right way to do a close reduction for a patient who comes to the emergency room and you have done a surgery, say 3 weeks back? Dislocation? What is
there are a lot of things. Yeah, a lot of things a surgeon can do if you get a dislocated hip in your practice. Number one is, if it is your case, you may have data about it, but if it is somebody else's case, once you reduce the hip under anesthesia, there are few things you can easily, with the use of C-arm, that is image intensifier, assess the amount of antiversion of the femur. You can assess the amount of inclination and antiversion of the acetabular cup, and you can assess the overall laxity of a tissue by doing a shuck test. So these three things you can easily identify on table after reducing the hip, just using an image intensifier or a C-arm. And if you know that there are mechanical issues involved in this, like the antiversion is less or more than what you need, or either a cup or a stem, then you must explain to the patient that maybe this hip will dislocate again unless we do something about it. So these basic things you can easily do after surgery. And if it is a soft tissue problem and it is getting reduced well without significant laxity, you may probably keep the patient in plaster boot derotation bar for 6 weeks. Not a very acceptable thing for many people, but sometimes it works if orientation of all the components are normal.
Do you at times use any hip spikers? In any cases?
Not hip spiker. You just need to have both ankle boot plasters and a horizontal rod. Patient can sit up in bed. That's not a problem. Hip spiker is too cumbersome and uncomfortable for the patient.
Yeah. So Rajiv, are you in?
Yeah, we have it. I could locate the PowerPoint that I sent to you.
Yeah.
So this was the solution stem, and that's how the proximal osteolysis we were seeing, and that's how it happened. that proximally whole of the bone almost disappeared. And that was the reason of dislocation. We initially tried to relocate it and fix it up with the fibular strut graft and additional grafts. And then after, when the patient was walking, this stem got broken. And removing this stem was a very difficult job, because the solution stem and the AML stem, they used to stuck very strongly, especially the solution stem. And that's how the major issue. And we had to do a mega prosthesis for this patient post-operative. And not just the mega prosthesis, and this proximally we fix up the lot of bone also. The abductor mechanism was also, we try to restore, and this was doing reasonably well. But as you see here, even post-prosthesis, this patient had a dislocation. And then after, we relocated it. We did again the resuturing of the abductor mechanism and try to give the immobilization to the patient for a period of about a month, as what Harish was just explaining. And then after, this patient was able to do reasonably well. This was the 2 years post-operative video of the patient. He could walk with the help of a stick, but he could do well. That's what it is. Yeah. In today's time, if I do, because this was a long back done surgery, about 15 or 18 years back, probably if today we do it, probably we'll use the dual mobility or a constraint liner.
Wonderful thoughts, Rajiv. So any questions from the panelists? Harish, any comments?
I have a comment. We must be careful with the overuse of distal fixed stems.
Yeah.
Because this situation can appear, of course, out of infection, but even if there is no infection, when you go with a pure distally fixed and you put so many proximal circlage, you can have a bone disappearing. And we must be extremely careful, because there is, in my feeling, an overuse even in revision of these distally fixed stems. Sometimes you can manage with the shorter ones, even with primary, not in this case, but many times you can.
Yes.
Including
This is a cobalt chrome stem. Cobalt chrome stem. Yeah, and this has a higher risk of fracture. I've seen 3 such cases. I have revised, and it's extremely difficult, because if you try to osteotomize, everything splinters. So we had twice used the hollow reamers made specifically based on the diameter of that stem which was there. And it took almost about 2.5–3 hours to get the stem out without damaging the entire cortex. So we don't use that stem because it's not as strong as the titanium stem.
Yes, removing this stem is a real big challenge.
The only way you can do it is by using trephines, and you need about half a dozen trephines to keep working on the distal fragment. But titanium tapered stems have always shown a better result rather than the cobalt chrome cylindrical stem.
Yeah, same was the issue with solution as well as the Achillon stems. The same story.
Yeah, this looks very strong, but I don't think it's in the long run, it's not very right to use it.
So Rajiv, I think we are overshooting the time a bit.
We it was a wonderful discussion. Thank you so much, Dr. Luigi Zagra.
Thank you so much. Very interesting.
For this discussion. We had a lot of very interesting discussion, very important cases that we have seen. Thank you so much for all the Indian faculty who could find out time for more. Probably we have overshooted almost more than 2 hours in this situation. Thank you so much, everyone. I think it was a wonderful discussion. Thank you so much, Manoj. Very well convened webinar. And friends, this webinar will be available to us on the YouTube, on our website, Indian Arthroplasty Association website, and also on the Facebook. So you can log on to either of them and be prepared for the next one, which is February 17th, the third Thursday of the February, where we are discussing the choosing constraint in primary knee. And Dr. Vikash Kapoor, our friend from Kolkata, will be the convener for the same. And also, lastly, I'll request that encourage your friends and colleagues to become the members of the Indian Arthroplasty Association using the emails given here. Thank you so much, everyone. We'll be stopping the streaming of it now. Thank you so much, Dr. Zagra, and thank you so much, everyone.
I thank you. Bye-bye.
Thank you. Thank you very much. Good night.
Good night, everyone.
Thank you.